Bonjour, bonjour à toutes et tous.
Good morning, everyone. We're very pleased to welcome you here in Paris and online for this first rehabilitation day at MSF. There will be sessions in French and English. There is simultaneous interpretation throughout the day in both languages. For those who are online on Zoom, you have a menu where you can select the language. And for those who are in Paris, in the main room, there are headsets for those who need interpretation. Today, we'll talk about quality of life, functional rehabilitation, and recovery. These are concepts which might seem far and remote from the emergencies we're dealing with every day. But at MSF, over the last 2 years, with the introduction of rehab specialty, we thought it was the right time to take a bit of distance and to take stock of the situation, because we were asked questions and we wanted to broaden the scope of the debate, considering the high number of needs that we have identified, and also the fact that there is a need to make these activities sustainable. These issues will be discussed throughout the day. First, we'll talk about rehab in a humanitarian context, which will be presented by Pierre and Julie. Then we'll go into two case studies on women's health and pediatrics. And after lunch, we'll have a presentation and we'll talk about outlooks regarding lower limb prosthetics. And then we'll have a panel discussion for the concluding part and what is to be considered in our future models of care. It's a new vision of care. That's why we need your engagement. We've planned for long Q&A sessions and discussions after the presentation. So for those of you who are online and here in the room, don't hesitate to raise a hand and ask your questions in the chat. And now I'll give the floor to Isabelle for the introduction from MSF presidents. Thank you, Clara. Good morning. Good morning, everyone, and welcome to this Rehab Day. Rehab, as you know, is an activity which has grown over the last years thanks to the contribution of the foundation, with 6 people dedicated to the implementation of rehabilitation in our various projects. We're talking 200,000 rehabilitation procedures, and these figures are still on the rise. The objective of rehab is to improve the quality of life of patients while reducing the impact of disabilities. Improving the quality of life, as Clara has said, is quite commendable, but it raises the question of the priority of this activity in a portfolio of various activities which are first aimed at reducing mortality. So there is the issue of feasibility and sustainability, because we know that physiotherapy and rehabilitation will be for a high number of patients, and we have a high cohort, a big cohorts at MSF. In surgery, it's a very good thing that in orthopedics and for the management of VVFs and trauma, rehabilitation is part and parcel of the care package, and that's a great progress at MSF. And it is an area where it was possible because of the small number of patients. But it's quite another story when you talk about women's health or pediatrics, where we're still at the exploratory stage, and we will be discussing the response today. In some projects, we might have to identify the most severe patients who will benefit from rehab, and in other projects, because there will be fewer patients who will broaden the portfolio of activity and provide different activities in these projects. I haven't mentioned it, but we will also discuss some specific aspects today regarding surgery and prosthesis, where we have little expertise as opposed to other organizations. Women's health and pediatrics is one of the priorities of today. I think that in the future, we'll discuss again the contribution of physiotherapy in rehabilitation for the management for NCDs. That's our priority for the forthcoming years. I'm sure it will be very interesting to discuss all this today, to make people more interested in it and make sure that in each project we will review what will be the contribution of this type of care in our project and accept to develop specific responses as a function of the project, as usual, I was about to say. And now I'll give you the floor. Good morning. My name is Julie. I'm a physiotherapist and I've been the referent for physiotherapy. I'll be introducing the topic with Pierre, who is also a physiotherapist and who works at the foundation on the development of the rehab activities at MSF. There is a bit of confusion at MSF between physical rehabilitation. So it would be good, I think, to define what we're going to talk about today. Well, first, what is rehabilitation? A physical rehabilitation is a type of care that is aimed at helping people whose functional abilities have been impaired for various reasons after an accident, trauma, after a disease, after surgery. It might be also age-related. So the main objective is to help those people to maintain, recover, or even improve their functional capacity, so as to make sure that those people will lead a normal life in an autonomous fashion. So you want to mitigate the disability and help people to go back to their normal life. It's very important to know that when you lose your physical autonomy, it does have an impact on the patient, but also on the patient's environment and the society as a whole. There are many types of rehabilitation therapies. You can't read the slides, but I had a few ones. So you have functional therapy, you have speech treatment, you have the prosthesis orthotist. Today we're going to talk about physical rehabilitation, prosthesis and orthesis. And at MSF, we are mainly providing rehabilitation, physical rehabilitation, and functional therapy in Amman, in Jordan, namely. In Haiti and in other projects, we only have physiotherapists, but after some training, they have also have been trained on functional therapy. So both our ergotherapy and physical rehabilitation have been introduced. The main difference between both is that physiotherapists will aim at improve every physical movement, force, mobility, range of motion, etc. That is, for instance, helping patients to walk again, while ergotherapy is about resuming daily activities. Like, for instance, the patient will be taught on how to eat and put on his clothes again. how to have a fork in your hand or a pen, how to use your pencil, for which you can rely on devices to help you. At the global level, these are WHO figures, 2.4 billion people worldwide will need physiotherapy care. That's one person out of three worldwide. Now, if we look into the detail in low-income and middle-income countries, the number of physiotherapists is less than one physiotherapist for 1 million people, meaning that more than 50% of the global population doesn't have access to physiotherapy. So that's quite, these figures are quite high.
On va un peu regarder l'historique chez MSF.
Now, what about physiotherapy at MSF? Historically, we couldn't find the very first date of a physiotherapist in the field. It started in the mid-2000, and thanks to orthopedic surgeons who've insisted and said, fair enough, saving life, but what about improving the quality of life of patients afterwards? So that's how the first physiotherapist went on mission in the field, but we don't know exactly when. In 2010, after the earthquake in Haiti, the first physiotherapist reference was appointed. Then gradually, we've noticed that some patients were severely burned patients who also needed physiotherapy care. And after their orthopedic management, we've added the management of those patients with physiotherapy. And in 2017, the foundation came to provide some support to develop new activities that are not necessarily aimed at targeting physiotherapy, but new activities for MSF. So today, we are present in orthopedics, trauma. We provide healthcare in women's health, pediatrics, intensive care, and also for severely burnt patients.
Merci Julie.
Thank you, Julie. My name is Pierre. I'm the physiotherapist for the MSF Foundation. Online, you must have the slides, but people in Paris cannot see the slides. We have a technical glitch. Sorry for that. I'll review the history of the involvement of MSF Foundation in this project on physiotherapy with the MSF Foundation started at the end of 2016, early 2017, sorry, when we started a project for the upper limb prosthesis, because we had some problems for those people who'd had amputation. We couldn't have any device, and we had difficulties in understanding their needs and provide them with the physiotherapy care that was in line with what they wanted to do and develop the devices that were needed for their daily needs. It was implemented in Amman in 2017. There was a pilot project, which is still underway today, where some 100 patients have been provided with upper limb devices and physiotherapy care. And as from 2018, we've started to further develop our activity targeting the severely burnt patient for those who had face burns. It's a technique which was rather complex and difficult to implement, and we've relied on 3D technology, producing images to process images remotely and provide access to care for those patients by using the face CT scans and 3D printing. This was developed in 4 countries, in Amman, in Haiti, in Gaza during COVID. And it was quite difficult because it was COVID and we couldn't move there. So we shipped all the equipment and devices, and everything was made remotely. But the team locally was already well trained on the physiotherapy treatment for burns. And then we went there and we worked with them after COVID. And then more recently in Syria, where we have this hospital for severely burnt patients in Atme, where 3D printing technique has been introduced for these patients who had face burns. And up until 2021, we have provided additional support for the management of severely burned patients in targeted projects or in emergency settings, like in Armenia, for instance. We provided some support also in Iraq and Haiti. And then with Julie, as from 2021, we could observe things in the field, and we noted that there were some gaps regarding physiotherapy for pediatrics, women's health, respiratory problems, and we didn't know what to do. So in 2022, we started a field assessment survey to identify the needs on the MSF France projects, trying to understand whether these projects indeed had the intention to provide physiotherapy care. First, whether physiotherapy was available there, and if not, what is it that we could do to develop something? And the most common responses were about pediatrics and women's health. So we've developed a project in 2023 with a pilot in Aidan in Yemen, where we've provided support to the mission to further develop their pediatric physiotherapy in a malnutrition setting. And we'll talk about it later on. From 2024 onwards, we carried on with our exploration of a need for pediatric physiotherapy. And then we started with women's health for oncology, for cervical cancer, and VVF in Nigeria. And now we're present in 14 projects, training on severely burnt patients, pediatrics, and women's health. Or maybe Julie can present the project where we're present. You see the map here with those countries where we have been or will be more active. In red, you have those projects that are underway. In darker gray, those projects who've been shut down. In yellow, orange, these are projects we're discussing in Mexico. They got in touch with us to try and see if we could provide some care for those people who are the victims of violence and torture. In DRC, we're trying to see whether we can introduce something for victims of sexual violence. Some figures again, in 2024, we were present in 19 projects with 100 physiotherapists, 5 ergotherapists, and 18 international specialists, mainly physiotherapists, including the foundation specialists. We've treated more than 14,000 patients, 184,000 physiotherapy sessions. This year, in 2025, up until the end of September, we've worked in 20 projects. More than 12,000 patients have been reached, 145,000 physiotherapy sessions, and 1,400 for ergotherapy. And this has been on the rise because in 2024 in Gaza, we've had to reduce the number of sessions for this type of treatment. But this year in 2025, they could provide more care. The graph here shows the number of patients which went to physiotherapy in green, ortho treatment orange for the severely burnt patients. That was the main activity for many, many years. And then there was a slight drop when some projects were shut down. And then there was COVID in 2020. Then we could ramp up again. And interestingly, the pink and the blue sections are emerging, pink being for women's health and blue for pediatrics. And you see that these two types of activities have grown recently. Same for the number of sessions, the number of rehab sessions provided to our patients. In so physiotherapy and rehabilitation, we have no difference, no breakdown between orthopedics and burns patient. But here again, you can see pediatrics and women's health activities that are on the rise. But you also need to know that the number of sessions per patient in pediatrics is much smaller than for burnt patients, because burnt patients will have a long course treatment in IPD and OPD with treatments which may last for several months, but you're not providing the same type of care as in pediatrics, for instance. And you can also see the difference between the number of patients, where you see women's health and pediatrics is on the rise, is almost 20%, but it's not the case for the rehab session. It's a smaller number, to add to what Julie said, because by the time we see patients for women's health and pediatrics, their hospital stay is much shorter than for orthopedic patient and burnt patient, of course. So keep in mind that pediatrics projects have just started this very year. So it will be at the end of this year that we will have a better idea of the figures. Now, the bottom right figure shows the HR in the field. In light blue, you have the local staff, locally hired staff, and in dark blue is the international staff. And we thought we had our presence were not that big, but there was a shift over the last years where the international pool has shrunk. There are fewer new people that are sent out in the field internationally, but we have the same people, over and over, who've developed their skills, like the foundation rehabilitation team that is often in the field. Now, there are challenges in the field, and I hope this will help link up with the next presentations, where there are a few things, patterns, trends that we find in MSF projects, and some of the examples which will be presented later this morning and today. So we classified these challenges in three categories. First, you have the acknowledgement of the disability and the need for rehab. Second is access to care. That is access to care in a sustainable fashion, and then resources. Now, one by one. Acknowledging or understanding the disability and the need for rehab is done at the patient level, but also the relatives, the family, and the local community. If there is a misunderstanding and we do not acknowledge and recognize a person's disability, how will the community encourage the person to seek care? There is a need for recognition by the institutions, by the medical teams, and by those policymakers to make sure that the rehab needs are taken into account and provided. And when you talk about disabilities, you have to consider the visible disabilities, mainly mobility related, and the ones that are invisible. And for women's health, we'll talk about what we call invisible disabilities. And there is a circle between rehabilitation, disability having an impact on the quality of life of the patient, and rehab, which also has an impact on the quality of life of patients. And this is working only provided the disability and rehabilitation are factored in at various levels. This will have an impact on access to care, because for access to care, you need to have trained professionals. You will have trained professionals provided the disabilities are recognized, acknowledged, as well as the need for rehabilitation, and therefore the need to train professionals. We also need to have a follow-up care of care. At MSF, we mainly talked about IPD, and we always wonder about the possibilities for patients to maintain and keep on having their care after our hospital stay. And that's not only true for rehabilitation, it may be true for other type of needs. And all this is pretty much dependent on various factors, such as the political setting and stability, and also the understanding by the local communities, plus the social and economic factors, like a patient who shows up at the hospital is not working at that particular moment. And all these factors will have to be considered when we consider this type of care in the long term for the patient. Now, depending on the missions, this can be done in our facilities or outside. And outside means to whom we're referring the patient. Should there be decentralization of care? Are those professionals trained? Are patients in a position to go there? And finally, there is a problem of resources. It's a cross-cutting issue for all our activities. You have the HR and the need for room and the equipment and devices available on site. And more generally speaking, the budget. And all these factors, all these challenges are more acute in emergency settings, and particularly when you consider the peak in nutrition crisis, and this will have a very specific impact on our practice, on the rehab care provided by MSF. So there will be internal challenges that are related to what I've just explained. If we consider this only at the level of MSF, what we see and what we've observed is often that there is a need to acknowledge and recognize the rehabilitation needs. In pediatrics, there was a gap there for some time, and now we have better acknowledged the need and also the integration within the multidisciplinary team. How can we make room for this type of care, which was not initially in the plan or in the project, and now we're hoping that it will be part of the package of care provided to the patient. Second, internal challenge at MSF is access to healthcare. It might be difficult depending on the context. We do not always have OPD care available in our various missions. And as a function of the settings, the introduction and deployment will be difficult. What you do for a mission in pediatrics might not be reproduced in another missions where the volume of patient is not the same, where the security problems is not the same, where access to care is different. And finally, as far as resources are concerned, there is the budget, of course, but is also the many activities are implemented, and there is a kind of a competition between the activities to be implemented, while the missions are already overwhelmed with a high volume of activities. So we need to find some ways to improve the implementation of these activities so that it would make sense in this particular setting. So we are exploring several avenues which will be discussed today, like awareness raising, the training of the teams, partnerships with other organizations that are specialized in some areas, and we'll discuss this afternoon when we talk about lower limb prosthesis, and also the HR model, which may be deployed with the local teams. How can we have better ties with the local teams to improve the patient management, and also the head office level, at intersection level, how can we make sure that there is a better acknowledgement and recognition of rehab? Today's platform is also an opportunity for us to talk about our teams. These are pictures of our teams. I hope that some of them are online with us. And we would like to thank them for all the work they're doing for our patients in sometimes very dire contexts. You have had, over the last 2 years, our team in Gaza has experienced terrible things. We have to mention our team in Gaza that is doing an outstanding work. And 4 of our staff have been killed because of the conflict. And we wanted to think about our 4 colleagues who've left. Abod, who was managing rehabilitation, Omar for functional therapy in the 3D team, Fadi, physiotherapist, and Reem, one of our physiotherapists who was also involved in the 3D project. We'll watch a video which was made earlier this year showing the work of the rehab team in Gaza, because I think that today Abod and our colleagues would have been very pleased and proud to show what they're doing. And I suggest we watch this video before we carry on.
يوميا في هذه العيادة بنقدم خدمات علاج طبيعي لأكثر من 100 مريض. لف يا عمو تعال علي. جبنا خياط ووظفناه معنا، فتحنا له مشغل خياطة صغير على أساس نقدر نقدم الأدوات والمشدات الضاغطة اللي ياخذوها المرضى، والموضوع نجح. قدمنا حتى الآن أكثر من 400 جهاز ضغط لهدول المرضى من البريشر جارمنت حالات الحروق. ساعدت ناس كتير، ولكن لا زال عندنا صعوبات شديدة بتوفير كل الخدمات بسبب نقص الإمكانيات والأجهزة المتاحة والأدوات.
Now, with this film, we also want to highlight what we do across MSF projects where rehab is done. All our teams provide excellent, fantastic work to take care of these patients, to restore these patients' functions and quality of life after their trauma. Now, let's turn to our activities, and among our activities and the activities that we're trying to expand, we want to have a focus on women's health. Elizabeth is our expert in women's health and rehab, and Clémence online, who is the women's health referent, and Raphael Kananga, who is the medco in Nigeria, where we have introduced rehab activities in Jahun for VVFs.
And we changed to English. everyone in the room is comfortable with it. And maybe I invite you to move a little bit, because it's been probably more than half an hour that you've been sitting. So if you want to stand up and sit or move around a little bit, we are changing subject quite significantly. Yeah, usually this happens when physiotherapists are, leading a session on whatever. So feel free to move for some seconds. And so I hope Clémence and Raphael are ready with us. I just wanted to tell you that I'll do a short introduction, but the stage will be actually for them. So moving to the first slide while you're still moving around a little bit, well done. As probably for most of you, it's obvious when we talk about physiotherapy in women's health, and especially if we localize women's health to the pelvic area, we often talk about disabilities or dysfunctions that are not quite visible, right? So they are frequently hidden, even though they may be visible when we think about a fistula, an obstetric fistula, and someone that leaks urine consistently, but still women find ways to hide it. It's quite, surrounded by shame, by stigma, by isolation. And it's quite dismissed all over the world, not only in the humanitarian settings where we operate, where we have our activities. So maybe changing, but maybe something to hear from you. When we think about disability in a humanitarian setting, probably the picture that is being displayed is something that illustrates quite well our understanding, right? Someone that has limitations with the upper or lower limbs, and that is using an assistive device that usually is not so high-tech, let's say, right? So, yeah. Moving then into the specificities of what we call pelvic health. And within the pelvic health umbrella, we have, of course, the pelvic floor dysfunctions. That is when something is not going on well. And just to clarify for you here and maybe online as well, that are not really acquainted with what exactly pelvic floor dysfunctions are. So we have 4 big umbrellas. We have bladder and bowel incontinence, or incontinence in general. So which very straightforward is the inability to control passing urine or passing stool, feces. Then we have the emptying disorders, meaning when we are not able to release. So on the other spectrum, so either inability to completely empty the bowels or inability to completely empty the bladder, leading to retention and obviously problems. Then we have the category of pelvic organ prolapse, which literally stands for the descending of organs that should be nicely placed inside the pelvis and all of a sudden move downwards and sometimes start appearing below the vaginal entrance. And then we have pelvic pain, which is a universe by itself. We're focusing quite a lot on pelvic pain experienced during sexual intercourse, which we understand that in the fields that we provide activities is quite frequent, but it's literally not only encapsulated to this area. So these are essentially what we would call the invisible disabilities. And then also in the settings where we've been collaborating with the projects, we have the not so invisible disabilities, but are frequently overlooked, like the obstetric neuropathies. Foot drop is quite acknowledged, also because physically, I mean, it's very visible when we have patients with foot drop. We tend to dismiss the mild to moderate presentations, thinking that they will just heal by themselves, they will, recover by themselves. But we know that some women that experience foot drop, mild to moderate presentations, if not addressed, they will continue with mild to moderate foot drop throughout their lives. Even more dismissed, and if we have any anesthesiologists in the room online, is pain, right? So I think it's a topic that really touches us all as clinicians and or people working in the medical field, because it's never too much to reinforce how much people that are suffering and from neuropathic pain, so which involves dysfunction of the peripheral nervous system and the central nervous system when it comes to the pain pathways, and how much patients are used to endure pain, and also still we clinicians are not putting enough attention there. We are so far collaborating with projects like Jahun in Nigeria and also Malawi, so the oncology project. And it's where we've been really dedicating quite a lot of our time and our expertise, let's say. But also we've launched some support to Bamiyan in Afghanistan, and you're going to hear more about it with Clémence. And we are also exploring the possibilities of moving to Yemen next year, to Hamir eventually, and Haydn. And so why for these projects and eventually for other projects, we don't really know where we're going towards in terms of future of pelvic floor dysfunctions, women's health, rehab in MSF. But why should we actually worry about these dysfunctions is, well, essentially because they really mess up with a person's sense of dignity to start with, quality of life, ability to participate, and there's a lot of isolation among women that experience these kind of disabilities in the humanitarian settings and not only. In the settings where we are operating, where MSF develops maternity projects, we know that most women are going to face multiple pregnancies throughout their lives. We also know that pregnancy remains as the biggest risk factor to develop pelvic floor dysfunctions. And not only they have many pregnancies, but usually they don't really wait enough time in between pregnancies. So less than a year after delivering a baby, they may be pregnant again while still breastfeeding. And this really implies a significant amount of stress to the body in general, and particularly to the abdominal and pelvic area. So these dysfunctions tend to be, again, underdiagnosed, underreported. If we don't ask as clinicians to women how are their bladders behaving, their bowels behaving, they tend not to take the lead to report on them, essentially because of what I already mentioned, that is this idea that yeah, it's shameful if the clinician is not putting attention on it, maybe I should not do it. And there's also this normalization of a woman that leaks after having had a pregnancy or having given birth. So which other activities are in women's health that are not linked to the invisible disabilities, but more visible ones? So also in Jahun, we are participating in the medical activities developed in the ICU. It's more into the concept of early rehabilitation, less specialized. And then we also know that there is a nice breast cancer project in Mali, running in Mali, and we've been discussing with the oncology team about it. And eventually it's something to consider for the future, given that definitely women that undergo breast cancer therapies like aggressive surgeries, radiotherapy, chemotherapy, eventually hormone therapy, will have the visible disabilities associated to the upper limb. And also, especially for the ones going through hormone therapy, the pelvic floor dysfunctions associated to a sudden menopause. Just bringing you back to the pelvic floor dysfunctions, even though in MSF we have maternity projects, we have oncology projects, and we are seeing patients in different settings. What is transversal to all these settings, clinically speaking, are the pelvic floor dysfunctions. Of course, the demographics are different, and if we compare, for instance, Jahun, where essentially we're talking about very young women with Malawi, which is an oncology project, and women that are averaging 50 years old. Of course, we're talking about prognoses that are very different. Also, the type of intervention that are provided in Malawi imply that the side effects, physical side effects, are much more significant, and therefore we are expecting that the patients in Malawi will be longer under physio than the patients in Jahun, which have a much better prognosis in a shorter period of time. But yeah, we have this kind of clinical algorithm that is transversal to maternity, pelvic oncology, sexual violence as well. We're not going to talk much about it today, but it's the truth. And also then breast oncology when women are under hormone therapy. And Raphael, are you around?
Yes. Yeah, thank you.
So Raphael, the medical coordinator from Nigerian mission based in Abuja, he's going to join us now, and he's going to give us an overview of the project and of the physio activities happening in the project.
Thank you so much,
In the
Elizabeth.
meantime, if you'd like to issue any comment or any question or move a little bit again, just feel free. Foot drop, yes. Yes, so foot drop happens frequently among women that are suffering of fistula, essentially because they all suffered from an obstructed and prolonged labor. So the babies remain for too long inside the uterus before actually being able to come out. Often they will need a C-section to be delivered. So that extra permanence inside the womb while the contractions, the uterine contractions to bring the baby out are ongoing, will imply a certain period of compression over nerves that are going through the pelvis and through the lower limb, and eventually damaging the nerves in a more or less reversible way. And that will give symptoms. The symptoms can be motor, meaning linked to inability to move in a more or less severe way. But essentially, the more common symptom is related to pain. When certain nerves or parts of the nerve are injured, they affect specifically the ability to lift the foot, the frontal part of the foot. And so then what we see is a foot that is dropped, that is not able to move upwards. The foot, the toes often. Yeah. Usually has a good prognosis, especially if the rehabilitation kicks in quite early. So let's see if we have Raphael joining.
Thank you so much, Elizabeth. Good morning, everyone. I want to take this opportunity to thank MSF Foundation to give me this opportunity to talk about the physiotherapy in Jaun, the largest sexual and reproductive health project in OCP. And I'm going to talk particularly with regard to the cases of obstetric fistula and the patient in ICU. So OCP intervention as per Jaun project is a long-term project opened in 2008. The initial objective was to support the Jigawa state MOH in the management of vesical fistula, vesicovaginal fistula at the Jaun General Hospital. From 2010, the project evolved to the area of comprehensive emergency obstetric and neonatal, the CMONC, in the same hospital, with the objective to reduce the maternal and neonatal mortality and the incidence of the fistula in the Jaun LGA. So Jaun LGA is one of the LGAs of Jigawa State in Nigeria, Nigerian mission. I think is finally, end of maybe 2020 or 2021, that the project tentatively began to take an approach to rehabilitation, suggesting some exercise to the fistula cases, health education and counseling. But it was 15 years after the project was launched that a true shift happened with the great collaboration of MSF Foundation. So I will say that since last year, which is 15 years after the launch of the project, we put in place a multidisciplinary approach that combine surgical, because at the beginning it was only surgical approach, but after then surgical and medical, let's say, but after then we started having combining surgical, medical, physiotherapy, mental support, and I would say somehow the occupational therapy. So this holistic model recognized that healing is not just physically, but it's also emotional, psychosocial as well. So the goal here is to restore the dignity of the patient, their autonomy. I think Elizabeth was talking about it, the autonomy and also the social inclusion for all the affected women. Wow, I can't see again. Okay, the presentation, okay, good. I think I have one of the question. Maybe some of you can still have this question. What is the relevance of the physio in Jaun project? I think Elizabeth tried to respond to this question. I will give also my answer to this particular question. I will answer this quickly by saying that the pelvic floor disorder does tend to worsen throughout time if no intervention. But if there is the pelvic floor therapy and surgical option, this can halt or reverse the progression of the disease. And this is what the team, they are really testifying what is happening currently in Jaun project. And in terms of future perspective, I think with this approach, Jaun project could be turned to a multidisciplinary training center for obstetric fistula care. For example, beginning of this year, we received a team from Ogba in Somalia. They came to learn from our experience in Jaun. Next slide, please. Hello?
Okay.
Yeah, sorry. Yeah. So here we have the data of ICU. So as I said, I'm going to talk mainly about the data in ICU and VVF. VVF is the fistula unit where we implement the physio activity. So for the ICU, you can see here that 43% of the ICU admitted patients were received by physio team as according to the referral criteria. Why I'm talking about referral criteria? Because we want to have also this approach of a multidisciplinary culture approach to put all the team together to address the problem. So the team, I mean the medical team, nurses, midwife, and medical doctors have been trained by Elizabeth, the referent, how to identify a patient in need. So they are the one who are identifying patient, but in the same time, physiotherapists, they can also participate in the round with the medical doctors and nurses, and they can also by themselves identify the patient in need. And you can see that is a lot, is 43%, and we try even to restrict a bit the criteria. Because of some challenges, I'll be talking about those challenges later on. We realized 1,801 physio sessions in 1 year because we started this activity last year in June. So from June 2024 to June 2025, this is the number of physio sessions we had. So in terms of functional outcomes, at discharge, you can see we have 664 patients out of 891, which is making 76% of patients walking independently or requiring mild support. So here we mentioned working capacity as a proxy to independence and participation in daily activities. Because the point, as I mentioned earlier, is we want really to think about the social inclusion of the affected women. Next slide, please. So, sorry. Sorry. So, in terms of the activity in ICU, we got a positive feedback from the team. The multidisciplinary team is not only medical doctors or physiotherapists. We got a positive feedback on the ICU length of stay. But unfortunately or currently, I don't have statistically data to confirm this impact on the length of stay. But here I want to place a great emphasis on the functionality for the quality of the life and well-being. This is, our main goal, the social inclusion of the affected women. But I think maybe with some data this year, next year, we can also try to understand what could be the impact on the length of stay. And we are also, can I say, based on some evidence in terms of earlier rehabilitation. That's why we are really working ICU. Earlier rehabilitation is proven evidence-based strategy for improving outcome in both ICU and post-operative patients. So it's emphasizing the earlier mobilization, multidisciplinary coordination, and patient-centered care approach to reduce complication and accelerate the recovery. Next, please. So here is in the VVF unit, fistula unit. As you can see here, all the fistula patients are admitted to physio. And in 1 year, we have 364 patients. And 110, they were already discharged from the hospital, so where it was physio, okay, how can I say? They started their physio as outpatient. And the total number of sessions is 2,100 physio sessions in 1 year. But you can see the discharge, the number of discharge is just, okay, no, I will not say it's just, is 80%. No, sorry, 80% is 88 patients, which can be like, if I'm not wrong, 40%. So these 40%, for us, we feel like they are really autonomous and they can really, they have good social inclusion as a final goal. We have. The goal here with the physio is mainly the continence. I think archiving continence is the true measure of success in obstetrical fistula care, while surgery is essential to close the fistula, but often it doesn't fully restore urinary control. So we need really physio. There is really a need of physio for pelvic flow, muscles training, bladder retraining, and these are possible only with physio. Next slide, please. So here I wanted to point out some challenges we had, and some project also can have the same context, and also to highlight some opportunities. I think Pierre mentioned some of them. The first one I think is in our settings, we face multiple competing priorities. And most of the time we talk about budget are tight, and physiotherapy is frequently sidelined. But me, I have just some question I wanted to ask to the audience. Is limited funding truly the main barrier to the physio implementation? This is the question I'm asking to the audience. And the second one will be, or do we simply fail to broaden our understanding of where physiotherapy belongs? Maybe a third question will be, do we consider that physiotherapy just post-surgical recovery and not a vital tool in maternal health, mental health, and social reintegration? The second challenge, I think, is in terms of gaps. The multidisciplinary team culture or approach is evolving, but gaps remain. Even here in Nigeria, physiotherapists are still underrepresented. Okay, I mean, generally in our national project, they are underrepresented, and to find them is a bit complicated. And many teams lack the knowledge and experience to integrate rehabilitation meaningfully into the women's health. But most importantly, we are witnessing, this is kind of opportunity, we are witnessing a shift toward a patient-centered approach. We prefer maybe to talk about survivorship model of care. Women are not just patients; they are survivors, and survivorship focus on the health and the well-being of the person from the time of the diagnosis until the end of the life. His ability to participate in the daily life, to regain autonomy, and to feel whole again is directly linked with to the quality of life and well-being. And here, physiotherapy has a direct and measurable impact, especially on the mental health on the affected patient. And I wanted also here to link the survivorship with our MSF commitment with the PCA, which is the patient-centered approach and the quality of care. Thank you.
Thank you so much, Raphael. We are going to get back to you in a while. Hopefully you will have more questions than answers. And we're going to welcome Clémence. Clémence, are you around?
Yes, hello everyone.
Mazal khair. It's late for you now, no? Okay, so from Jahun, we are going to, so not Jahun, Nigeria. We are traveling now to Bamiyan in Afghanistan. And Clémence, thank you so much. Thank you for your patience as well. And on to you whenever you're ready.
Yeah, thank you, Elizabeth. So I'm really happy to talk about the Bamiyan project and most importantly about women's health. So I would say that the reflections about Bamiyan project started with a change in women's health culture. We were more focusing on mother and child, and now it's more about women and girls and babies. And this change in culture made the reflection about Bamiyan a little bit like to understand why we thought about it. It's also to think about safe deliveries for mother and babies. Now we are thinking more about safe but also positive experiences, more respectful for women and girls, more autonomous choices for them to decide how they want to deliver and in which conditions. It's the same with the post-abortion care, that we were taking only the complication from abortion, and it's been some years now that we went to the safe abortion care as well. And now more and more the women want self-managed abortion at home. So you can see also the progression of the mentality and the culture in women's health. Another example is the family planning. We were a lot talking about family planning. Now we say contraception, and we were talking about it mainly after deliveries. And now it's open to anybody, women, girls, in the community, etc. And the goal is to have these methods, all methods, proposed in all projects, not only in maternity settings with midwives. So no, not maternity settings with midwives. The other one another example of women's health components is sexual violence. The sexual violence, it's the same. The approach is not anymore in the maternity, but it's to have an increased access in all projects by any medical professional, not only midwives. So this shift of culture between mother and baby to women and girl centered approach, I think it made the project of Bamiyan go from this idea. Can we go to the next slide, please? So here it's a slide just to show you as well how this translates into numbers. So as you can see, the number of deliveries are mainly stagnating for a few years. Sorry for the axis, it's not really nice, but it's just the years. So you can see that it's mostly the same for the number of deliveries, but the number of safe abortion care, sexual violence, and contraception is increasing and increasing quickly the last few years because of this approach where we are not anymore only based on the maternity settings with midwives, but also outside of the maternity and most importantly, outside of only mother and babies, but yeah, women's and girls. Next slide, please. So here it's a little video to show you the roads of Bamiyan and to give you a little bit of context. So this is a setup where we have a midwife, one midwife in each locality. It takes around 3 to 4 hours to reach this locality, and it's very, very far away in the mountains. And this is during summer, so you can imagine during winter with a lot of snow, it's very difficult to do referrals, but also for people to be able to access care. So it can be that they have any kind of complications. They are just going to this little health center. So we have 8 health centers in Bamiyan province. All of them are very difficult and complicated to reach. And all of them have just one midwife. And now we added one nurse. So the midwives are seeing all women and all girls of the community. And as you know, with the context of the Taliban, it's very difficult for women to access care in any case. So the idea was that these midwives, a little bit alone, have more skills and more knowledge about all the care that they can provide, not only obstetric, but also gynecology. So yeah, you can go to the next slide, no problem. So for the gynecological part, the first thing that we thought, it was when the Medco called to say that they want to give back the speculum. They are not using them, so maybe we can do a donation. So from there, we understood that they had some difficulties to do gynecological consultations and to know what to do in this or that case, as midwives who are not really trained to do that. Usually it's a gynecologist and voila. So we also had the idea of having gynecological consultation, but to do a survey with the women's health physiotherapist, Isabelle, to understand a little bit what are the main diagnoses or main things that they are seeing as symptoms. So the team did a survey with 62 patients, and it was very interesting because 82% were symptomatic, were showing symptoms. 79% reported 2 or more symptoms. So it's huge, and mostly it was urinary incontinence, so leakage of urine. They were leaking urine. Then the other one was pain during sex. The other one was pelvic organ prolapse. And the last one, it was constipation. So as you can see, it's things that when you are super far away from everything and you have urinary incontinence, you have a midwife maybe 1 or 2 hours to reach. You will tell her, I have urinary incontinence, or you will not tell her, but you will have this problem. She will be the only person to be able to respond to these needs. So it was a lot. And from this, we did a training for the midwives about sexual and reproductive health in general, like women's health, but also about physiotherapy. And we mixed a little bit, we integrated the physiotherapy part in the women's health components. Next slide, please. So what happened, what we would like, and I think it's taking shape slowly, is that during the consultation, they add or they link the physiotherapy in their practice. They are lacking of some of these steps, but they are getting there slowly. So, for example, during history taking, do you have any allergy, or do you have any, how many C-section, etc.? They are adding questions on bladder and bowel continence, or pain during sex, or symptoms of prolapse. So it's an integration of their history taking. Another one is during the physical examination from head to toe that usually they do to check the conjunctivity. They are adding a pelvic floor assessment. Of course, if there is no infection, the woman is not in labor, etc. So they do this pelvic floor assessment to as well have more diagnosis and treatment. So we added, even in the data, the pelvic floor dysfunctions and the treatments of pelvic floor dysfunction or interventions, like, for example, exercises 3 times per day, etc. So it was very interesting because they had a lot of patients, but also themselves, they were having some pelvic floor dysfunction. So it was really interesting to link the women's health with pelvic floor dysfunctions, because it's really linked and it makes them more assess the pelvis and also look with the speculum, ask more questions and have more interaction with the women. And at the end, the education and follow-up by a lot of things are the same, be it the diet, the exercises, the follow-up consultation. They are all intricated between each other. So it's very interesting as well to see them taking more knowledge and more skills to be able to provide better quality of care. Next slide, please. So the reflections on this is, of course, we have some challenges. So, of course, it's a new skill set for midwives that they need to integrate, but it takes time and adjustment. It's not from a day to another that because you know a new skill that you will put it into practice. So it takes time to do it. Fortunately enough, as you can see in the picture, we have some good news from the midwives. They are sending some picture on WhatsApp to say that they are practicing and doing group of women in the community to teach them about these new skills that they had. So it's super good, and they are using more and more speculum. So we're getting there. But still, it's an adjustment to do, and maybe not the full package of skills will be put in place. The next thing is that the women are satisfied of this care and they are happy to do more exercises, but they are asking injections and pills. They say, you don't have a treatment for me, like I'm leaking urine. You just tell me to go home and to do these exercises. I live very far away. So they want really to have pills and injections. So it's something as well, it's a culture not only of the midwives or of the public, but for everybody, it's a little change. Also, it's an integration that would need more support across the year. As it's very difficult to reach there, and because also of the number of expats who can go, it would need more advisor visits, more trainings, more support for them to be able to do it and to practice it and to get better at it slowly, or because they are very separated, even one midwife from another. They cannot they cannot reach each other to. So it's a little bit more complicated than we thought. But the midwife supervisor is a very good ally, and she's continuing to address this. Also, we don't have the capacity for now to support women requiring specialized care. In Bamiyan, there is not a lot of options, so they would need to go to Kabul. And yeah, it's something that we could do from time to time, but for now, it's not possible. And of course, there is a risk for midwives because, as you saw from the first slide about the women's health dynamic, midwives are taking more and more subjects on their shoulders, be it sexual violence, safe abortion care, deliveries, contraception, etc. We would like to see more midwives involved in physiotherapy, but also we need to think about how we can share this with other professionals. Here in this case, it's very specific, but we would not like to have a task shifting, but more task sharing of these new skills. Next slide, please. So the future perspectives that we have would be to have more recommendation and guidelines available, written, but also trainings online, etc., just to make it a little bit more formalized. We were really trying here in Bamiyan to see how it goes with them, and it was successful, we can say. So we are keen now to develop guidelines and recommendation. Of course, we need to talk about it and see, etc. But I think it would be super interesting for all the midwives around the world. And also to take the lessons from this project of Bamiyan and maybe replicate it or translate it in another setup. That would be interesting, but of course, each project is very different from one another. So we would need also to adapt the strategy and what we would like. For example, for sexual violence programs, or for hospitals, for example, for maternities like Haidan, where we have physiotherapists who are already there and where the midwife could only refer these patients, so only diagnose and then refer the patients to the physiotherapist. So it just a first project, a first pilot. It was very interesting, and midwives, as you can see, they were really involved and really happy to learn new things, especially that we are seeing a lot of gynecological problems and we don't have gynecologists around. So what do we do? If we have physiotherapists, that's perfect. If we cannot have them, how we integrate a little bit of this care into our practice. So this was my little things for Bamiyan, and I'm available for any questions.
Thank you so much, Clémence. Yes, and just in continuation of what you're saying, maybe just to clarify that in many settings around the world, in the perinatal period, meaning during the pregnancy, in the acute phase after delivery, in the PNC period, so up to 6 weeks after delivery, midwives and physiotherapists working in women's health do share, let's say, this topic of pelvic floor dysfunction. So midwives are quite active in this area in many settings around the world, being the UK being a good example, Canada, Australia as well. So yeah, Raphael and Clémence, please stick around. We are going to pass on the mic to our audience in a few seconds. Just stressing how much of a burden these pelvic floor dysfunctions may represent to women that suffer from them. Don't take me wrong, men also suffer from pelvic floor dysfunctions. We are concentrating, of course, the topic on women because they are disproportionately affected, and because, of course, it suits our maternity projects and our activity. But the burden is for everyone suffering from them. And it starts with, as any disability, but I guess this one, because it really affects our intimacy and aspects of our life that we tend to protect particularly. So the sense of dignity is particularly affected when this are ongoing disabilities with no support being offered. There's a lot of studies, especially on urinary incontinence, and it's incredible how even mild presentations of urinary incontinence throughout time play a significant role or imply a significant toll in women quality of life. And then this association of these dysfunctions with the decrease of physical activity. We know that when women are particularly active, they tend to have more urinary leakages, they tend to have more pelvic pain, they tend to have more problems with their bowels when they are suffering from these dysfunctions. And so the natural trend is, I will drink less water because then I will leak less. I will move less because then I will have less leakages and so less embarrassing situations. And this, perpetuated in time leads to people that have a sedentary lifestyle. And we know more and more how sedentarism, withdrawal from physical activity really prones people to a lot of potential non-communicable diseases associated, of course, with depression and so on and so on. From more social point of view and starting with family, especially in most of the settings where we operate, we see a massive percentage of women being abandoned by their husbands and often isolated by their families. They feel, again, shame as well, especially when we're talking about leakage of urine and leakage of stools, given the obvious expression of this. And we don't really have economic studies done in our settings where we operate, but with some numbers from the US, we understand that the withdrawal of these women from society participation comes with a big toll, economically speaking, both because they produce less, if at all, and they imply quite a lot of expenses from the health systems. So thank you so much for your attention, for your patience as well, for all the technical issues. And we would really love to hear from you. If you have questions or comments, yeah, it will be great to have a discussion. We have.
Thanks a lot for the presentation. I have a question for Raphael, maybe, and also for Clémence, for both projects. But for Raphael, I was wondering, I understand that you don't have a baseline on mobility after, I didn't know if it was discharge, but we must have some anecdotal level of feedback from the women themselves or the staff even to have a sense of the kind of before and after since we started doing rehab in the project. So that was one of my first question is this one, to have a sense of what's the feedback in terms of how it is received, appreciated, etc. from the persons themselves. My second question is regarding the challenges that we face having implemented this activity. I was wondering for Raphael, because I'm sure you have a different level of also Elisabeth of thinking about it, but at Raphael's level as a medco, what is the nature of your discussions on rehab? What are the questions that you wonder for next year, for example? Do you have questions of the volume of activity? Of course, always regarding to the available budget, but that's true for any kind of activity. But so when you reflect upon it, is it a problem of volume that we would like to do it on every woman and we can't, and then discussions on inclusion criteria, or is it a question of the quality or availability of human resources, I don't know, Nigerian physiotherapist or model of care? I didn't quite get from the presentation the nature of the challenges when we go a bit a level beyond the competition of all of the different activities that we have on the project, which would probably be for any project. So that's my second question on Nigeria. And for Afghanistan, for Bamiyan, if I understood well, I feel that you meet some challenges, but nothing that's insurmountable. It feels like we can overcome most of them. I mean, the one that I'm not entirely sure about is that you said, Clémence, that this activity would need more visits of more trainings and more support in terms of getting the ability to do this activity for the midwives there. So is this, practically speaking, is this feasible to have more visits from people? Is it a question of or not? And so we think that's kind of the limit of what we do, is that we're going to do it a little bit, but with a we're going to accept a decreased level of, in terms of the quality of the in the activity, right? So yeah, this I wasn't sure whether we feel that in fact, we can make it work, and it's kind of key in the project, or what are the real challenges that we don't really see what we're going to do about them. Clémence, would you like to start by responding to the last question, and then we go from there?
So it's a good question. This is why as well we ask for another advisor, because we just have one MIO for all the women's health, and you can see that it's crazy, and more projects want to see. And also I would say that a lot of people don't have this knowledge about midwives and how to put in place a SAC and SV, etc. So it's the full package, and that they want an expert coming, putting everything in place, and voila. So normally, if I understood well, we will have another advisor. So yes, we will have more time to go and to do a proper thing. And no, we don't accept that the quality of care would be just a basic, and we just click a box. So I think with the 3 advisors on women's health, it would be perfect. We will need to go there more than before, that's for sure. Also, we have the online trainings. We have a lot of WhatsApps with the midwife supervisor and we have the PMR who has a background of midwife, and we ask for the next one as well to have a midwife PMR, so it can help. And for the other, for the other challenges, I think I said that it's manageable also because it's a small project. We have 8 midwives, so it's manageable. For bigger project or with much more midwives, I think we would need another approach. This is why it's for now it's working. We will need to find other ways for each different project, and yeah, so there is no one size fit all. But for this one, I'm hopeful that it will work.
Of course, in Bamiyan, there's one particular limitation, that is the project can only receive visitors from, I would say, they cannot receive visitors from November to March, which then make congestion a bit of visit intentions, right? And it's a matter also of prioritization. So we know that when this training launched by Clémence and myself happened, we understood that the baseline of technical skills that the midwives were presenting were still not great. So when we think about the classic midwifery approach to ANC care, eventually even delivery and PNC, so of course asking them to add this extra layer of being concerned with the pelvic floor dysfunctions as well felt probably as okay, there's quite a lot that we have to put in our pack of care that we were not considering before, not even our basics, right? And so on top, we are being asked to worry a little bit about function, rehabilitation as well. So I guess that what it will take will be some time, and from the project side, from the mission side as well, to keep this topic as something to put attention on, and not let it, just slowly lose the momentum and the energy that was launched during this investment of training the midwives and having them super engaged during the training. It was really inspirational to be there and seeing how they were grasping the topic and not really shying off and saying, oh, you're asking us to do one more thing. So they were actually interested in bringing this as part of their pack of care. Anything else that you'd like to add to this, Clémence?
No.
No, merci.
Yeah. Okay, good. So maybe we move on to Raphael. Would you like to answer to the second question, Raphael? And then maybe I can bring in some information about how the MDT in Jahun perceives physio in ICU, and yeah, some great feedback we've been having from them.
Yeah, thank you very much for the two questions. Maybe for the first one, I think as Elizabeth, she said she will be the one giving more element according to the feedback we are getting from the patient. But from the team, I want just to point out that we are really having positive feedback, as I mentioned, in ICU about the length of stay, but we need to do some analysis this year or next year to try to have evidence on it. And you see the percentage of working as a proxy for the independence or autonomous of the patient in ICU is 76%. For the second question, I think as Pierre mentioned, and we are facing multiple competing priorities. For us, for example, in Jaun, we had this discussion with the team to say, okay, what do we need to do again for the physio? What are the needs and what can be done in the project, taking in consideration other needs. So Jaun, we are talking about in total, I think almost 2,000 deliveries per month, both CMONC and BMONC. So we have some challenges with the HR, quality of care. So we needed to make some choices. So for us, it was like, okay, let us improve what we are doing currently in physio. Maybe, let's say in terms of equipment, having small equipment which can help us to improve what we have been doing for now. And later on, we'll see if we can review the inclusion criteria. But this point is because we took in consideration other priorities, as I'm talking about the quality of care in general, the HR needs at the project level. So this is really a big challenge because we need to think about the volume of the activity and also the quality of care. What are the just middle and juste milieu to find and yeah, to be in the middle.
Thank you, Raphael. Yeah, acknowledging the huge project that Jahun represents with a huge volume of patients. It's an 18-year-old project, but you know, emergency is a day-to-day activity there. And yeah, understanding that an activity like physiotherapy, somehow a young activity everywhere in MSF can easily get lost among the non-priorities. But I guess we've been working well towards bringing some visibility to the activity and some investment, and while acknowledging Raphael and the project for the efforts now made to rehabilitate the physio structure, so where the physio is being provided, and it's ongoing, almost finalized, and it's, of course, it was a lot of back and forth to bring physio, to map physio as well on that concern. And then replying to your first question about, yeah, we don't really have data from before physio was a thing in ICU. So how were the patients leaving ICU, right? Were they walking? Were they being transferred lying down in a bed? But we do have spontaneous, by the way, spontaneous feedback from the medical team, essentially, acknowledging how a big part of those 43% of patients that are admitted in ICU that are coming for physio, how they used to stay for longer periods, let's say over a week, because consistently in Jahun's ICU, and we have this lady here that knows it very well, the average length of stay for the totality of patients is around two days. So it's, you can imagine like how speedy it is to admit a patient and discharge a patient. So of course, it brings also a window of opportunity for physio intervention as quite short for some patients. But the ones that are, you know, among those 43 that end up being for physio are, of course, the ones that stay longer. They are diluted among all the others that are admitted, and so it feels that it doesn't really change the average length of stay. We don't think it's a good indicator to decrease even more the time that these patients spend in ICU. I don't think it's what we should aim for, but for what we've been observing and what we've been also receiving as feedback, that is, the patients are leaving the bed earlier. Literally, sometimes on the day they are admitted. They are leaving then from ICU to IPD, so they are stepping down to IPD in a better physical condition, very often by their own feet, so walking independently. And the way that the overall ICU MDT embraced physiotherapy, the presence of the physiotherapist, and literally included the physio in their team, is it's really beautiful to see, and I guess it shows immediately that they feel this resource as a valuable one. To try to bring a bit more of figures to how the patients are, especially after they leave the hospital. What we're going to launch soon is going to build some criteria for this, but we're going to do phone follow-ups to some patients that leave ICU not so great, so literally not really walking on themselves, 2 to 3 weeks after they are at home, to understand how has been their integration in their daily life activities and so on.
When will be next?
Thanks a lot for the presentation. I have one comment and one question. So the comment is on what you just said. I was privileged enough to be in Jawoun during your first visit, and you just felt in the right place at the right time. Like, it feels so obvious that so they have neurological problems, they have respiratory problems. It's the physio care as a holistic care you provide from like head to toe and taking the patient as a whole. That made a total sense. So I don't think we have figures. We'll just have personal feedback, etc. But as you said, it seems so obvious that yes, there's a clear benefit for these women and subsequently their family supporting them through these hardships. The question is a bit about data. Do you think we'll get enough data to, I mean, the people in the room are probably already acquired to this concept, but for the MOH, for example, to get a buy-in from the MOH, because if I recall correctly, it's not that easy to find physiotherapists in Nigeria, even less for the north. But do you think the MOH will adhere to this, adding this? They're already struggling for the basic obstetrical care. So how can we get on board to add this thing that I guess, again, for us is a bit obvious, that needs to be integrated into the package? Will they be on board, or is there any discussion related to that? It's for you and for Raphael, I guess, but I know less about Afghanistan, but
I think Raphael can talk more about it. But what happened in Nigeria that was quite fortunate is that of the 2 physios that we have working there, one of them, the ICU physio, actually it's an MOH physio under incentive. So already it showed some level of involvement of the MOH into wanting to be part of this. And then Raphael, would you like to add any more information to Aurélie's question?
Sorry. Okay, how can I say it? Jawoun is a small town. Sometimes I used to say that is a village, so it's difficult to have all the component when you want to have a comprehensive approach. And even I can put a link also with Katsina, where we implement physio in the ITFC, which is a pediatric hospital. To get physiotherapy in those contexts is quite difficult, because you can even recruit some for like 1-2 months, and then after that they resign because they prefer to go back to their area. So this is kind of big challenge. We didn't start really this discussion with MOA to see how this, I don't know if I didn't get really the question, how to integrate maybe their activity, but we want to focus mainly on what we are doing now taking in consideration the challenges of finding a good trained staff who can really help us to have this comprehensive approach. I don't know if I respond to your question, but. Hello?
Thank you, Raphael. I have another question for Clémence. What was done for the woman with a vaginal prolapsus, which is not a so small number? It's, if I'm calculate well, 29-30% of the number of women screened. And well, there are different ways to take in charge of prolapsus, and I was curious to know what was done, or what do we plan to do?
Yeah, so it's a good question. It depends on the degree and the severity. And for the patients that we saw, it was only, but Elizabeth can speak more about it, but it was only exercises. And then we follow up and we see if there is a better, if it's going a little bit better. An organ prolapse that is too severe, they would need a surgery. But quite a good number of what we saw, if I don't say something wrong, Elizabeth, you were saying that no, these ones, they just need exercises. So it's also to know the degree. And if it's too much, yeah, they would need to go to Kabul.
Thank you, Clémence. Yeah, complementing your answer. So when we ran the surveys, the surveys actually took place before Clémence and I visited. So there was no physical examination involved. We actually don't know the severity of those prolapses. So they were just surveying on prolapse symptoms, and then because there's a checklist that already clinically tells us this woman for sure is suffering from a prolapse. So of those patients that were surveyed, we don't really know the severity. But I can answer to you what would we do, right, if we would diagnose a prolapse. So the first line of intervention is definitely physiotherapy with exercise, with constipation management, which is quite prevalent in these populations as well. When we talk about constipation, of course, we don't talk about constipation that is there for a week. We talk about something that is there for at least 3 months, and that has a set of criteria to be considered as chronic or prolonged constipation. So management of constipation with, of course, nutrition, input, water consumption, and then of course exercise as being the gold standard, and that would be for women that suffer from prolapse grade 1, grade 2, and some grade 3s that may skip surgery if they really do things well done and in a very committed way. Grade 4 prolapse with a complete externalization of the organ has straightforward indication for surgery. Yeah. Very useful. I thank you for asking that. Yes, thank you for asking about that. Yes, it would be another layer of care. So still the first line of intervention always is exercise and behavioral changes, to just mitigate like constipation and so on. Also, if they're overweight, which in the case of Afghanistan, we didn't really find anyone overweight, on the contrary. But the prolapse would be definitely another layer of care that we hopefully will have that conversation at some point soon. Yeah, we're just starting from the basics here. Yes. So we're not doing pessaries just yet.
No, but sorry, it seems to be a detail, but it's not, because if we are talking about pelvic problems, so the prolapsus is really very prevalent and the most severe consequence. So there is all the nutritional measure, of course, not so easy to implement, but they are part of the treatment. Physiotherapy, of course, but after there are surgery at the last stage, but in the middle, like the vaginal pessary, which I don't think is something so complex. So I was just wondering if we go in that field. Okay, we start with nutritional support, and we will see later on for the next step. Is that okay?
But thank you for the provocation on that sense. Yeah, it's not even that budget-wise it would be too heavy to consider, but it's true that the pessaries would require follow-up. So usually 3 months after pessary is put in place, the patients will need to come to clinic to to confirm that everything is going on well, no infections and so on. And it would require a certain level of hygiene as well. And during the clinic visits that Clémence and I did, I mean, we went down to very basic stuff as, talking about hygiene, intimate hygiene to these patients. So I think it would have a place, but it's not as a first line of, implementation, let's say. Yeah, but you are right, because exercise is paramount, but it does not solve all cases of prolapse symptoms. We're not even talking the prolapse itself; is the symptoms that really provoke, disability and so on. Yeah. Thank you.
Thank you. I have a question for Jaron too. Just my question is relative. It's about the tension between quality of care that you mentioned, Raphael, and the volume. At the same time, you set up the physio project. I don't know if there is some reflection regarding the what could be the minimal package of care that could be provided in this context, adapted to the context. That this could the package that could cope with between the volume, the demand, and the quality what we can provide. And regarding the Clémence, you talk about it, the task sharing, the task shifting, but I don't know in Jaun if you have an experience on that, if it's physio and only who are working on that. Just my question. And also just relating to the loss to follow-up. I don't know if in Jaun if you have some loss to follow-up among your patients. You didn't talk about it.
Thank you. Thank you so much for the question. The tension, quality of care, and the volume of the activity. This is really a reality here in Nigeria in all the projects. I think we'll be talking about Katsina also in the afternoon. So we have to restrict the criteria. We have to really restrict the criteria, thinking that okay, we can't cover all the needs because we are talking about, as I mentioned earlier, we have 2,000 deliveries, but in the hospital is around 600. So if we want to do something specifically for each patient, it should be complicated. I used to say that we don't have to create a monster in Jaun. Jaun is a small town. We don't have to implement everything covering all the needs. So we need to make choices, as I was mentioning before. So what we are doing is to restrict the criteria. We started last year with the VVF because we feel like VVF, all of them, yeah, I'm talking about 100%, but VVF, the capacity is 55 beds. We are going even to reduce to 45 next year. So we feel like those patients, at least all of them, they can have access to the physio. And then after that, when we feel like we cover the need of the fistula cases, we try to find also other patients in other units which may need physio. So we identify the patient in ICU, and then I think we can see also in IPD, in some IPD, if we can also identify some patient. This will be maybe the next step. But currently, what we agree is, okay, in terms of quality of care, specifically in terms of physio, let us concentrate on fistula and ICU patient. For the second question, sorry, I didn't get it clearly. Maybe, sorry. Sorry.
No, it's just an example of Clémence of task sharing, task shifting in Bamiyan, but I don't know what is the Jaun experience on that. Yeah, and also I don't know, Clémence, you can answer also why what is the limit, because you said that this you prefer task sharing than task shifting, but what is missing to do task sharing, for in Barga? Go ahead.
So in Jaun, currently is physio. We are talking about a multidisciplinary approach, culture, or a team working culture. But the medical team, let's say midwife, they are overwhelmed with what they are doing. So to have time also to work on some specific things which are related with physio, they don't really have this time. So that's why currently is physio doing their part, and we have also mental health doing the mental health support. But the good thing is we integrate this activity in the project. Is not only physiotherapists who are identifying a patient in needs, can also come from a midwife, from nurses, even from medical doctors. Thank you.
Yes, so to add, I would say that it depends on the project. I think it would need to be tailored to what the midwives are capable to do in the context where they are. In Jaun Simang, yeah, the midwives are completely overwhelmed. It's not possible. But of course, if we invest in focal midwives dedicated to the activity of physio, but I think that physio are much more trained and will be much more qualitative than a midwife to train. So for this, no. But I would say maybe for the BMONG, to have a midwife who can diagnose at least the problems, and if they see that there is this one in PNC, it's been a month she delivered and still she's leaking urine, yes, to have a certain way to work with the physio, that would be interesting to do. It's just that we need to tailor for each project and each context. And yeah, it's difficult to say, let's do this or let's do that for everybody. And especially that it's not something that we have in our curriculum. No midwife is trained on physio from the one we have in the pool. So it would take time as well for them to be acculturated to this. But to diagnose, I think it would be feasible in the next 2-3 years, and to really have the link with the physiotherapy. So it can be something that we can work on. Or we say, no, we want more physiotherapists and we want to, it depends. Everything is possible. I think we need to think what is the best interest of the patient. Is it to have the midwife who does sexual violence, who can do also the physiotherapy and mental health, and or we divide by the best person who can do the best care for the patient. And yeah, it's a calculation that we need to do depending on the context, the midwives and what we have and the budget, and voila, I think it's like this. But I'm not against, I'm not completely blocked, but yeah, it will take more time if it's a midwife to be trained and to be able to manage properly. But there are other options, I would say. But I think Elisabeth will have better overview of what she would like to do next. I will try to follow.
Thank you, Clémence. Yes, I guess, the short answer could be also that in settings where physiotherapy is possible, physiotherapy should be privileged, right? Should be considered. It's not the case, of course, in Bamiyan, where we have, isolated professionals developing a wide set of healthcare to patients. As much as possible, they are trying to attend to the patient's needs. This is what we're proposing in Bamiyan is very much linked to their midwifery role. So it's very specific. It's community based. So, and not like Jaun, where again it's essentially an emergency project, right? So we have emergency cases, so of course, if we have staff that is overwhelmed already with their baseline tasks, it's not. It's not. We should not be asking them to add any further tasks, particularly if it's not classically part of their set of tasks. In Jaun as well, just very quickly, I can share that we did run also this pelvic floor dysfunction surveys among the postnatal care clinic. And what we got was also a huge number of patients in the postnatal phase complaining of pelvic floor dysfunctions. And then it's something that we've been discussing with Raphael. What we found as well was a team that is managing the clinic that is overwhelmed with the dozens of patients that they have to see per day, and finding it difficult to incorporate very simple questions as how is your bladder functioning, how are your bowel functioning. And so if the patients do not come with obvious signs of leaking urine or a foot that is not lifting, they are just not asking them anything else. And so, and it's, you just have to be reasonable here and keep the discussions ongoing, but understanding as well what is the capacity of the teams in place to enter in this broader considerations regarding patients' health. I see your.
If I may add something,
sorry, Clara. No, just for me. We are talking about what is the best practice, because asking in postnatal care the woman regarding the leakage, or for me it's part of the basic of examination. I think it's not a new activity. That I think to do a best and good examination of patients and history taking, and also the capacity of responding. It's another thing, If we don't have, but to do the basic examination of the patient with best practice, I think we have to do it. It's not adding to add a new activity to the team. But the question of to respond, to provide care to this woman, our capacity is another question. We have to separate, For me, it's a basic.
Yeah, so this is what I wanted to continue about. Just a comment, it depends on the activities. If you have 100 patients to see per day, you will not ask this question. You will just see the blood, and if she has any sign of sepsis, you will go to the emergency. You will not go into the details, and that's the problem. That's what is a big change of culture that I was talking about, because we are more into this phase of having very large numbers, very large number of patients with very few HR, doing a lot of things just to make sure mother and baby are safe. And to change this culture, to go to the gynecological part, asking how is it going with your husband during sex? Do you leak urine, etc.? I think it's the gynae part that is not an emergency, that we remove too quickly from our practice. And this is why Bamiyan is super nice, because it's a small amount of patients, a small team, and we will need to find the balance and to find the continuum of care with a little bit less pressure on the midwife to do emergencies. So it's very complicated to prioritize and to find the proper adjustment, but I think we need to go that way. Otherwise, we will continue to just do popcorn deliveries, but it's not it's not anymore in 2025. We cannot continue to do it.
Just maybe to add quickly, I think the big challenge is the volume of activity, as mentioned by Clémence and Elisabeth. But for OPD, I think we'll try to do this something this year, because during the MAP, we try to suggest to reduce the workload in the OPD. So as Guyguy said, is part of the basic, but they are overwhelmed. They can't ask all the questions. So yeah. But I think it should be possible next year if we got more HR, medical doctors, midwife, and even other position. Thank you.
I have a question in particular in this situation where the needs are huge, and it's not possible to increase all the HR or everything and etc. And also in our medical ambition is to involve more the patient in her own care for this case. I know that it will not replace for sure physiotherapy done by a specialist, but how we can also teach the woman to do the exercise at home or to have this kind of plan de soins. I don't say it's easy because I think they have many things to do in their own life with the children, with everything, but I think it will be something complementary which will be developed. Maybe it's done, but I wanted to have your opinion about this case, who should permit maybe some progress.
Very important point. So we have a very public health approach to our patients in the sense that the care that is delivered requires a very active participation of them, right? And so always with this reinforcement of information that, okay, if you do your work now and if you get your results, but if you cannot, if you don't continue doing them throughout your lifetime, even though of course in a lesser dose, let's say, your problems may return. And we always instigate them to share this with the women that are around them, of course, in their community, their family, and so on. I guess as the teams are maturing as well, in Njahun, in Malawi, essentially, where we've been kind of putting a lot of work, as the teams are maturing and we have a stronger baseline involving the health promoters more and more as well, and this, teaming more with the physios is for sure a strategy to follow in the next few months. Yes. Anything on your side, Clémence and Raphael, to complement?
Yes, maybe to say that the pool also is evolving. The new midwives, the young midwives, I will say, I'm considered an old one. The young midwives are also into this approach, and sometimes they will have questions, and they will ask questions about this. What can we do about the prolapse? What can we do about infertility? Before, I think we were not really into this mode of looking a little bit around. So that's also a good thing, that the pool of midwife is also dynamizing, I don't know how we say, making me more dynamic on this subject. So that's super good as well.
Thank you, everyone. Maybe you have more questions, but let's allow them for the afternoon. We need to shift to pediatrics, but not before. Just please an applause to our guests online, if you will. And so I'm very happy to transfer the word to Lucile. Lucile is our specialist in pediatrics, working also for the foundation. And yeah, on to you.
Thank you, Elisabeth. So, hi, we will switch in French for this presentation. So,
hello, everyone. My name is Lucile Saint-Louis. I'm the pediatric rehabilitation specialist for the MSF Foundation. So we're going to highlight PEDS rehab and try and answer your questions, of which I assume there are many. Now, I will also be joined by Emmanuel Berbain, who is the nutrition referent at MSF OCP, and also Jules Anthony Barga, who is a former project medical referent of Kano's project. Kano is the first project where we introduced PEDS rehab in a nutrition project followed by Katsina, and I'd like to say hello to our teams online, because I'm sure that the physios are watching us, and so I'd like to thank them for the wonderful job they do with kids in the field. Hello, everyone. Thank you very much for this invitation and also your involvement in physiotherapy, which is an absolute must. Now, let's try and highlight the situation of our little patients. Now, this is Hamed, a 3-year-old with generalized edema. He was saved. He's on the picture. He's sleeping and he's now stable. However, his future from the physical, functional, neurological point of view is very much compromised. So if you want to do anything about nutrition, you take a look at the WHO's guidance, and they tell you that whenever there are chronic problems, it's important to go for physiotherapy, speech and language therapy. Now, I'm sure these WHO's experts are very good people. However, it seems to me that it's lagging behind the various problems that are faced in nutrition projects. Now, this guidance is also something that we get from WHO, is translated into our own guidelines. Now, just an update on nutrition. You know that the main target is 6 to 59 months. You know that there are two forms of malnutrition, marasmus and kwashiorkor, associated with edema and most of the time associated with quite extended skin lesions, looking like burns when they are very severe. Now, with RTUFs, we've been able to show that we can treat 85% of children in OPDs. However, there are some children, and more particularly in Africa, where you see kwashiorkor even in children who are older, and in particular in Yemen and Afghanistan. In our case, we see younger infants. It's more due to comorbidities or breastfeeding problems. Now, a few words about food insecurity. I know that it's something that may be debated upon in-house as well within MSF. Here you can see the curves showing the number of people who do not get access to proper nutrition and therefore are undernourished. And on the left-hand side, the situation in 2008, you can see the we go from 10% to 8% of the prevalence of people who are undernourished, and you can see that there's a renewed surge after COVID and also following the various conflicts. Now, food insecurity is something which is on the upward trend in Africa in particular, and when we look at the trends, well, it's not good. Now, a few words about our OCP activities. You can see that whether it's ODPs or OPDs or IPDs, it's very much the same. And here you can see what is the case in Katsina, one of our largest projects in the past few years, and you can see you get an idea here how difficult it might be to introduce new specialties in the management of these patients. You can see 10 deaths per day in late August, September, and with children who present with very severe conditions. Now, some clinical cases, but it's just to give you an idea of the needs we're faced with. The top right-hand side picture is a child with this flexion contracture in both legs with skin lesions in the flexion, in the flexed areas. And we may remember, all of us, some children who were considered to be able to be discharged, however, who look like this, and for whom we may wonder what it's going to be for them. And there's also beyond the range of motion, there's also edema in these children. Now, nutrition is something which is cross-cutting and also involves different disciplines. We think physiotherapy is important to be in the loop, and there might be, of course, situations where it is more difficult, but SAM corresponds to the most fragile population of children, and in a situation where we have to deal with a lot of patients. And it seems to me that all players in the field should make sure that we cater for those needs. And honestly, I'm quite impressed with the work done by the foundation. It seems to me that physiotherapy is, on the whole, something that we tend to deep prioritize.
Remember the ramping up and the scaling up of physiotherapy for severely burned patients, and I would compare it with nutrition, certainly not for all children. There is certainly some detection to be made, but it's absolutely key. And reversely, on the right-hand side, you see patients who also need nutrition management, which is not the case everywhere. And we do have the products for that. Thank you.
Merci Manu. Donc c'était pour vous poser un peu le contexte en termes de malnutrition.
So that was for the overview regarding malnutrition. And a few years ago, Emmanuel did inform us and warn us about Katsina with his children with retraction. And if we suggest rehab in these settings is to avoid such cases where the condition of patients is such that they have to be referred to surgery if we want to have a functional recovery of the patient. For the next 10 minutes, I'll try and shed light on what we do in pediatric rehab, because this morning we've talked about grown-ups and adults, but often in the field we are asked, what do physiotherapists do with children? I didn't even know it could apply to children. When I started to work at the foundation, I was identified as the one who is playing with children. So I'll try and show you that we do not have the same objectives. And if you have further questions on the difference between physio stimuli and psychosocial stimuli, I will be ready to answer such questions. So Julie defined it this morning. So we have a patient with an impaired function impacting their autonomy, dependence, and participation in daily tasks. Our objective is to restore the function or to mitigate this impairment, to help the patient to be as autonomous as possible. Same with children. But it's not so obvious because children are in development stage. You know, they will be crawling before they actually walk, because all their steps, these steps are important for their development because they allow them to explore their environment and to learn about the world around them. And there is also play. Play is what the child will learn to learn things in life. When a child doesn't play, he doesn't develop in all areas of development. And playing is a tool, and it is through playing that they learn things. Playing is like a tool which would be common to all of the people working with toddlers, young children. This is why speech therapists, psychologists, physiotherapists play with the children. But playing is not the objective of our procedure. It's just a means to achieve our objectives. And our objectives are physical and functional, as you will read on the following slide. And we'll talk about the first type of patients and the needs that we found in the malnutrition project. These patients have a neuromotor delays. Neuromotor abilities is the acquisition of motor skills from birth to walking. As I said, you know, sitting, crawling, standing up are part of the neuromotor development. And it will help the child to identify his body. He doesn't know the upper limb, lower limb, right and left, as you see. So you have the primary motor skills that will help the child to explore his environment. And by exploring this environment, the child will discover the world around him. And it's the basis for the global development of the child, that is, in other areas such as the cognitive, social, emotional, and language development. Now, in the first month of life, there is malnutrition, there will be a lack of energy, discomfort, and stress in these children. And it will be impairing the acquisition of the motor skills. So if this is limited, it will have an impairment at each and every stage of the child's development and will ultimately have an impact on the overall development of the child. And studies have shown that children with malnutrition have development delays, and this is often assessed when they access school. And as I'm specialized in the neuromotor development, we can intervene earlier before they actually go to school, because then catching up once they're at school is very difficult. For these neuromotor delays, I've taken the example of Kano. This is where we have the highest number of patients with this condition, but on average, in all the projects that I have explored since I have started, we have some 25% of malnourished cohorts presenting neuromotor delays.
Next, prochaine slide, s'il te plaît. Merci.
The second type of patients are the ones described by Emmanuel earlier, kwashiorkor, with severe edemas. The edema is painful skin, lesions are painful, it will limit the capacity to move around for the child. A child who doesn't move around will lose some muscle mass, and there will be some limitation of their joints. In Katsina, as Raphael said about Nigeria, we have big cohorts of patients, and in Katsina, typically, we have a severe edema in a high proportion of cohort. In Kano, 3 hours away, the proportion is much bigger in Katsina than in Kano. Now, based on the human resources and the equipment we had in Katsina, we decided to do things well and not too quickly. So we have had to reduce the list of criteria. And since many of these children stay in hospital longer than others, some will stay for 3 weeks in hospital. Those patients with high risk of comorbidities and infections because of open wounds. And it seemed to us obvious that we should focus on this category of patients. And what we've observed is that the typical patient in Katsina are children who've had started to have malnutrition after 1 year, because kwashiorkor usually sets after the end of breastfeeding, after weaning. They stopped walking, and they would come back to Katsina every year up to the age of 5, because the malnutrition starts again, and mothers are not told to stimulate their children. So the simple advice to mothers to stimulate their child for physical activity can really change the outcome of these children. What about the impact on patient? I have started to provide you some answers, but in Kano and Katsina, what we've realized is that the spontaneous motor skills have improved. Those who are having a delay have developed skills. Their children are seeking to explore the environment, because the child you've seen on the previous picture, you see that in his eyes, he's just in misery and suffering. And we involve mothers, and they're happy with this type of management. And we teach them how to do that at home once the child is out of hospital. And I'll show you a video now. He's a 31-month child, Katsina, with a severe edema, with wet dermatosis, open wounds, and he couldn't sit up. And he had a problem with the hip extension. So that's a picture of this child who didn't want to play, was not interested anymore, no drive at all. And the video, you will see that he starts playing. And that was 5 sessions later. So he's out of bed, and he was taken to our physiotherapy room. And you see that he more spontaneously would start playing. He's sitting up, and mobility is back. It seems that the physiotherapist is playing with him. But during the 5 first sessions, he had to build the confidence with the child and try and see in which moment the child needed to move around. He wasn't moving anymore. You see, he's crawling. He wouldn't walk anymore. And you see, you can't hear. The physiotherapist was calling the mother so that she would be part of the session. And really, 5 sessions, he's back on his feet. Even though it seems a bit difficult, he's doing better. So he was walking like that, but you could see his face. It was painful because he still had edema in his legs. And as I said, the edemas are painful. And the mother said, because she was very happy about the outcome, because they were all very concerned when they reached the hospital, and she was very happy for the help provided by the physiotherapist in Katsina. So, when implementing this physiotherapy, what did we do? We had to adjust to the local challenges. In the MSF settings, we've realized that we have access to the patients as long as they are in IPD in hospital. So we said, as long as the patient is within our control, we have to treat him. Ambulatory treatment would be good because it's over time, but when you talk about neuromotor skills that are transient delays, with 3 sessions, this is what we've done in both projects, 3 sessions per patient, Kano and Katsina. These are not neurological delays. Just by working on the environment of the patient and by training the mothers, we can have very good results. So we've had to develop specific strategies to ensure follow-up care and continuity care. So we did a lot of coaching of mothers. We did encourage mothers to be involved to make sure that the mothers will take over these activities. And what we're hoping for also is that once the mothers have been trained themselves and they're informed, they will help other mothers in the community to stimulate their children. This is what we did in Yemen. In another setting, we have an ambulatory ward, and we had mothers who came to consult with the physiotherapist immediately because the mother had spotted a delay in the motor development of their children. So that's really good because there is a relay in the community. Now we have a 10-month child in Kano. He never sat, he never called, and she talks about another mother who didn't want to show up at the local healthcare. Sorry, we have no sound, but you have the subtitles in English.
En gros, le kiné est en train de lui demander en quoi son enfant s'est amélioré.
Physiotherapist is asking the mother how the child did improve.
Ce qu'il n'avait jamais fait avant. Et sur la deuxième partie de la vidéo,
And in the second part of the video, she will explain what she's understood about the physiotherapy management. She's understood that it would help children move around.
c'était un enfant hospitalisé. Ouais.
And the child was hospitalized indeed. When you do not explain the child how to move the body, he's not going to do it. So we were quite happy with this testimonial because the mother has clearly understood what we were explaining.
La slide suivante, s'il te plaît. Encore.
So in practice, as we've said, also regarding women's health, we're faced with similar challenges in the MSF settings. We need to work with the hospital staff, identifying the patient, reporting, and nurses and a nutrition assistant can help also be all day long close to the patient to promote the development of these children. So our approach is that when we implement our program in a project, we have a awareness raising effort to all the team members of the hospital staff because they don't realize that there is a need to take into account all the aspects related to the environment of the child. We promote also multidisciplinary team approach because there are always difficulties in identifying the patients. Physicians have difficulties in identifying the patients. Physiotherapists are good at that, but this is what it takes time in a program. You know that prescribers, physicians will spot the kids, detect them. It's not in the MSF guidelines when you focus on malnourished children, but it is in the pediatrics guidelines. So I think that if it was also in the guidelines for malnutrition, it would be easier to introduce rehab in our program. It's a personal feeling. It seems that as long as it's not in black and white, the physicians who are already overwhelmed will not necessarily consider the development aspect of these children in their diagnosis. But we also have external collaboration for patients who need more rehabilitation. It's a big town in Nigeria, and there are local associations providing care to children with disabilities. So our physiotherapists in our center will identify those most critical children. We identify children with permanent disabilities, and they are referred to other physiotherapists who will carry on the continuity of care. Another question, therefore, arises, what about training physiotherapists to make sure that when we refer the children outside, that the other physiotherapists will be equipped and skilled to take care of these children. Now, I'd like to show you another video with two questions to Mubarakil, who answered two of these questions. What were the challenges when you started to work on the project in February this year?
When I joined the project, I encountered two key challenges. First, working with malnourished children with developmental delays required me to acknowledge malnutrition as a major humanitarian crisis in my locality and understand its impacts on children's quality of life. And then again, trained to offer appropriate interventions for developmentally delayed patients due to malnutrition. Secondly, the challenge of educating the team about what we were introducing into the project. The question of whether malnourished children are well enough for physiotherapy was always debated due to accompanying health problems and vitamin deficiencies. So we had to do a lot of convincing. Five months into the program now, I face very distinct challenges. Increased workload, Despite physio team growth over the past 3 months, our workload has surged due to the peak, making it challenging to keep up. Interdisciplinary coordination is another challenge. In a fast-paced multidisciplinary team like ours, I need to negotiate with other healthcare providers to access patients for sessions, which differs from traditional settings. Communication with caregivers could be challenging when convincing them about neuromotor delay, particularly in younger children. It requires sensitivity and effective communication.
Désolée. Donc, vous pouvez voir qu'il résume un peu des problématiques.
So you see what he summarized are problems that are similar to what we've read about women's health, multidisciplinary approach, explaining what it is to integrate physiotherapy in an existing program. Now, for the last part of this presentation, we should be with Anthony and Barga, medical reference for the Kano project for 1 year. And he followed up the implementation of physiotherapy in Kano. We have a slight connection problem. So in the meantime, I'd like to talk about the prevention during with physiotherapy. When we offered at Katsina children physiotherapy or neuromotor rehab in Kano, it's because we have identified a functional risk for the future. And in children, we wait to see the symptom before treating it, and sometimes it's too late. When I consider neurological lesions, if the lesion does exist at birth, it's always wait till the child is 2 years old, and then you start the care while you're losing an opportunity, because during these 2 years, there is great brain spasticity that will help for the learning, and neuromotor skills might not seem a bit of a problem, but we know that if we don't do it now, it will be more difficult later. Well, if the child is in a walking age, it's far more difficult to catch up. Another thing about Katsina, as you said, as you've heard, we've had to set priorities. It doesn't mean that the children do not have neuromotor delays. Just like in other projects, 25% of the children have sometimes very severe neuromotor delays. It doesn't mean that there isn't any, but the little we're doing as best as we can. I think that now Anthony is with us. I hope you can hear us. Yes. Yes, I can hear you. Okay, so now you have the floor. Thank you. Hello, everyone. I'll be speaking in French, but my slides are in English. I was asked to talk about the operational challenges, the prospects at Kano, which was selected for this. I was there from September 24 to September 25. So it was said by the previous speakers, physiotherapy here is here to improve the quality of life for the children who are in the ITFC. We have integrated physiotherapy in 2024, and in 2025, it was really more concrete in April. In Kano, it is for children under 5 who are malnourished, and these children were admitted in the ITFC, the feeding center. Kano is in Nigeria, in Western Africa, and we are in the northwest with more than 22 million inhabitants. The metropolis has more than 8 million people. So that's just to give you an idea about Kano. And also I'd like to say that unlike what people might think, malnutrition is not like malaria or other problem. It's more complex. There are several factors: poverty, food insecurity, social factors, poor weaning techniques, because and there are also cultural factors. And in this case, you also have IDPs and conflicts. I will be talking about the operational challenges and the outlooks from the operational standpoint. So I'll talk first about the HR difficulties and challenges. You will certainly agree when we say that we started the recruitment. People had their certificate and diploma, but had not been exposed to pediatrics and even less so to malnutrition. And in Kano, when the project was set up, it was set up for approximately 75 and then up to 200 beds. And we needed to have a vision for 35 beds, but during the peak season, we had one physio for 75 beds. Waiting time was long, and it had an impact on the quality. And I'd like to talk also about the infrastructure, because in Kano, we initially had one ITFC, but we ended up with two, and most of the resources went for life-saving activities. And the actual, that was the actual treatment of malnutrition. Physiotherapy was ranking second. Now, since it was a new activity, it was a bit difficult also to have it integrated in the clinical workflow. Sometimes there were delays in referrals, and sometimes the clinicians were focused more on the life-saving priorities, sometimes ignoring or forgetting physiotherapy. Another operational challenge was the same as you have in the baseline level of a project. But these challenges remained. Sometimes the patients' records were not properly filled by the clinicians because of a lack of time, because of their workload. We heard earlier about workload, which was sometimes too much, preventing clinicians to ask the right questions. And that was also the case in Kano. We also had some monitoring, and eventually we could find a solution to this. Another problem, which I think was mentioned by Lucile and also by Emmanuel in his introduction, is the continuity of care, which is not always possible because you have 7 or 12 days of stay in the ITFC. You're not always supported as a patient, meaning that the care stops at the doors of our clinic. And Lucile has talked about this awareness raising, which has to be made. And also there's a need to engage further the patients. And there is another problem, which is that it seemed that what we wanted to show was not really understood. So we think there is a gap in research, and we want to show the impact of physiotherapy on some of our patients, you know, those who received the indication and were treated. And for those who were not treated, try and compare cohorts with one arm with treatment and indication and the ones who had indication and were not treated for the second arm. I think this type of research could be useful so that decision makers would have figures at hand to help for decision making. And I've also said that sometimes care was fragmented because of lack of collaboration and because people were talking a lot and not really acting. And we did not always have this multidisciplinary approach. People were working in silos, but we've started to improve this. And I've said also the fact that the continuation of care with toys. You know, the toys were available in the ITFC, but not outside the hospital. So we have engaged in another activity to help with the toys.
With regard to capacity building and training, when we consider outlooks, we think we should increase the number of physios to have a good ratio so that the physiotherapists are not overwhelmed and can do good work. For infrastructure and equipment, I think that you were told that we would like to have more rooms and more space for physiotherapy. Now, this is no longer a newly introduced activity. Next year, it's going to be 1 year that we started with physiotherapy. So we'd like physiotherapy to be part and parcel of the patient's pathway, and also with a clear referral pathway, and also that patients get access to physiotherapy after discharge. And we would like to enhance the ratio. We had only 3 physiotherapists, and it's not enough considering our number of beds. Now, data collection and monitoring. Now, we do have physio-related data in DHIS2, for instance. So things are changing, and there's going to be better tracking. Continuity of care is absolutely paramount. We also need to have physiotherapy in TFCs. When you consider that these children stay for at least 6 weeks, if we could offer physiotherapy to those children, it could improve their quality of life. We also suggest that community health workers mention physiotherapy when they visit. Finally, before I give you my conclusion, I think we really need to make sure that there's actual patients' engagement. We haven't been able to do so far, but I think it's going to be the case next year because we've been teaching methods to create toys from locally available materials. so as to support continuity of stimulation and exercises at home, so that, you know, children continue to get access to stimulation once back at home, so that it's not something they experience solely in hospital. Then the integrated approach is something we started, and this combines physiotherapy and psychosocial stimulation. We think that it can help maximize recovery, and especially when there are large numbers of children, and we can hope to improve the outcome in the future thanks to this integrated approach. And we also think that it's important to have operational research to measure the impact of physio in IPDs and OPDs. Now, in my conclusion, I think it's goes through all the points that were mentioned. We've seen that physiotherapy is important for malnourished and pediatric patients. And I think as a clinician that really this is important. And the videos, the films you could see, well, tell everything you need to know, and it can't be overlooked. Of course, operational challenges must be addressed with capacity building, infrastructure creation, also new HR, and we should stop considering physiotherapy as something on the side, but we should make sure that physiotherapy is really integrated in the patient's pathway and also engage the community. Continuity of care is absolutely essential and should be improved. And research also is important so as to deliver data that may underpin what we do. And here's my last slide to say thank you. Thank you very much, Anthony. Now you got some a warm round of applause, Anthony. Hopefully you could hear it. Now, these little patients are in Katsina, and it's nice to see them smiling. It doesn't happen so often. So thank you very much for your good work with these vulnerable patients. And the MIO, Russell, tells us, and this is the team, what the team tells us, pediatric physio is where science meets play and healing meets hope. And I think this is a very nice conclusion. And before we go on with Q&A, Dr. Yanou, who used to be a medco in Waka and who is now in Niger, and who says that in Western Africa, the mothers recommend to massage the kids with shea butter, and it's a good starting point to use this as an entry portal to teach mothers to stimulate their babies. And it reminds me of what I was told when I started. I was told that mothers wouldn't really embark on that, and we can see that it's not the case, as we could see with the testimony from a mother in Katsina. Thank you very much for this interesting presentation. Now we're all convinced at HQ that physiotherapy is important for pediatric patients. but we need to make sure that we can transpose it into more settings. And it's always this question and problem of peak management. What do you do with your cases when you are overwhelmed by the number of cases during peak periods? Nutritional stimulation, physiotherapy, what is the link between all this?
Oui, ça marche. Je pense j'avais une slide qui montrait ça.
One of my slides highlighted this. I'm not so sure I can retrieve it right away. However, of course, playing and mental health activities mental health activities aim at improving the bond between mothers and babies. And we know that whenever there is malnutrition, mothers may feel guilty and withdraw, as it were, from supporting their child's development. So psychosocial and stimulate activities were introduced in order to deal with this sort of problems, the psychosocial aspect. And with physiotherapy, you deal with the physical aspects of things. It may be a bit of a caricature, but it's really making the link between the mind and the body. And you can see that a physiotherapist also physiotherapy focuses very much on the problem at hand, whether this is mobility or range of motion or and play therapy. The play therapy is a bit generic. You may not know exactly what it corresponds to. In fact, it's using playing for sick children in order to stimulate the children, to help them move around and engage with their environment. Now, whenever there are malnourished children, you can just give them toys and you leave them alone and you don't give any advice to mothers. This is level 1. Level 2 is to have someone who is trained to explain to their mothers how they should use their toys, these toys with their sick children. They know how to play with their children when they are in good health. They find it more difficult when the children are ill. And then, so this is level 2, and level 3 is targeting, which is even more precise. So level 1 and 2 is just for all children who are ill and in hospital. And when, in Kano, as Anthony told you, they integrated psychosocial stimulation and physiotherapy. They have a health promotion team, and we love working with these people because they know how to relate to mothers. And every week, there's 1 hour of discussion between the health promotion team and physiotherapists. They highlight the importance of playing with children, and the physiotherapists also demonstrate what you can do or invite mothers who are on the point of being discharged to show what they can do, because all mothers with malnourished children have to or can benefit from learning how they can interact with their children. Now, you can therefore have joint sessions with physiotherapists and psychologists playing with children. A physiotherapist focuses on children, and the psychologist focuses on the mother. And so these sort of sessions that combine physiotherapy and psychology are very, very valuable. Now, STEAM-NUT or STEAM nutrition is the protocol that is based on action against hunger to suggest a psychosocially structured management for mothers to help them to go back to a certain routine. And in the STEAM-NUT protocol, there are some exercises to massage your child to reinforce the bond between mother and child. And we think that maybe we could complete this with something of physical stimulation, not just to reinforce the link between the mother and the child, but really to something that would focus more on physical activity and physical stimulation. I want to stress again what can be taken care of by fields when faced with huge volumes. And I'm coming back to this idea of task sharing and task shifting. So in this case, it could be shared and shifted to parents. Now, STEAM-NUT is one thing, and maybe I think we won't be able to have psychologists and physiotherapists working together in the field. It's not going to be feasible, considering the volume we're faced with. So how can we suggest simple tools? STEAM-NUT offers tools that were tested in ADRE. So what could we integrate in the STEAM-NUT toolkit in terms of physiotherapy? Now, this is why I was telling you that we are discussing with the STEAM-NUT team. Now, when it comes to task shifting, task sharing, it's always very difficult to hand over your know-how. If you consider basic activities like physical stimulation, you can train non-specialists. However, it does increase the burden of training for people we would like to train. And this is why we asked about task shifting in the field. Of course, we can train nurses on exercises to stimulate physically the children, but then you want the nurses to be dedicated to this particular activity. Otherwise, it's impossible for nurses to deal with their workload and have this on top of what they do daily. Now, if you can't offer combined psychology and physiotherapy follow-up on an individual basis, well, having this in a group setting could also be valuable. And I told you, level 1 is basics, you give toys, level 2 is more structured, and you try and teach mothers how to use toys with their kids. But this means also having dedicated staff for this. It's not that easy. You may think that just having toys is going to be good enough. However, it doesn't suffice. You have to also have IPC in place for toys. There's a lot of thinking that goes into just using the toys in a proper way, and because it does require some sort of protocols. And there are places where it's possible to have this. However, whenever there are physiotherapists available in the field, I think it's interesting to see what you can do. Now, all this is very much across the board. Now, there are so many parameters that come into play. However, in the longer term, for our operations, I think that physiotherapy is really a part and parcel of management, of care. However, the other activities could be outsourced. 2 weeks ago, I attended the Pediatric Resuscitation Congress, and we had presentations about all these things that can be done outside the hospital, and maybe we could outsource some of these physiotherapy activities. For a steam nut, I think there's one thing from the operational point of view. We don't need to have psychologists. We need people who have some training on psychology, but and we could have some health promotion HPE that would be involved. And I think we could well, let's say we could shift some of our activities that are not purely medical in order to lighten the workload. Yeah, just one thing I like to add to what Emmanuel said. I think it is important to have this introduced in the protocol.
On ne saura pas. On a perdu la connexion, Anthony. Je sais pas si
I think we lost the connection to Anthony. Now, psychosocial stimulation is very much at the heart of what we told you, but physiotherapy is also in charge of dealing with other things, such as kwashiorkor patients, for instance, and of course, there are also patients who are in a coma or patients suffering from neurological sequelae. And of course, we want our colleagues to be trained specifically. So physiotherapists in nutrition projects isn't confined to physical stimulation, obviously. And of course, it's difficult to shift all these tasks to other professionals. I'd like to say that several colleagues online say, and more particularly one from Bangui, and stresses the importance of the capacity building for mothers to have them on board as health partners. So what is your take on this? And Drissa Sibé, MSF Waka, tells us that about the implementation of protocols and that physical therapy should be introduced in nutrition protocols. Also comments from Oman. They have a physiotherapy project to monitor patients remotely. Is it something that we could implement maybe one day for children? So rehabilitation. Now, mother's involvement, engagement. Obviously, I do agree with the team in Bangui. It's absolutely essential, and it's probably why mothers are so happy when there are physiotherapists in malnutrition projects, because then they tend to be involved. And very often, even if this is a medical question, they turn to the physiotherapist because this is the person they more easily relate to and share their concerns with. Of course, it's important that they should be on board to then guarantee continuity of care once back home. About protocols. Yes, indeed, it should be introduced. Now, malnourished hospitalized children are covered by a protocol in the PEDS guide. In the nutrition guide, you get only what pertains to nutrition. But I think it's important to give a detailed presentation because, of course, these are pediatric problems, but with some specific issues associated with malnutrition. And I'd like us to put pressure on WHO because this WHO guidance is applied, enforced everywhere. And some experts we talk to have a very keen interest in what you do. And the greatest experts globally argue that nothing significant has been done, more particularly for deployment. And this is what you can see in the literature, nothing on physiotherapy in malnourished children. Yes, indeed, nothing has been done, or well, let's say not nothing, but just a few things. And Handicap International has also tried to push for physiotherapy in malnourished children. And tele-rehab about this, well, it's something we could contemplate. The only thing is that you need the equipment to make sure that you can talk to these mothers. Sometimes they may not have a smartphone or no phone at all, but not even a phone. So if you can get access to the patients, yes, indeed, you could send exercises. You could also assess the how far the child has improved. So we could do so remotely after the first consultation and have the mother back with the child if there's a need for it. Now, Kano, our physiotherapist there, is saying something interesting about the difficulty to refer the patients after discharge because the clinics are involved in orthopedics or neurology, but they don't know a lot about the neurological disorders in malnourished children. So he says, well, maybe we should raise the awareness among these healthcare professionals. Thank you very much, Mubarak, for your comments. Yes, indeed. Kano patients referred to physiotherapists outside the hospital really have well identified conditions, delayed motor skills. Well, we don't know to whom we could refer those patients. So indeed, in the midterm, we would like to be able to train our partners to whom we refer our patients to raise their awareness in malnutrition so that gradually maybe they could introduce this in the physiotherapy syllabus in Nigeria, because they have a very good level of education, but physiotherapists in Nigeria could also be trained on malnutrition. Now, there are several questions on the team matters as peer counselors, HB. I find this is maybe difficult to have the clinical team get involved, and therefore you see sometimes a lot of tasks shifting to the physiotherapists from the nurses and doctors to physiotherapists. And my candid question to you is to say, of course, these are malnutrition projects, so it's large volume, but in a well, for instance, you get a bit of orthopedics or burn patients, so it's smaller. So do you think we could have people with a profile able to be adapted to all these situations? Because in these projects, like in a well, there might be also reasons for delayed development. Do you think it would be feasible? Well, thank you very much for your question. Yes, indeed. There's also task shifting in the other way, in the other direction, and not only for physiotherapy. For instance, communications with the patient is something that is shifted to the health, to the HB. So when we're told that nurses can monitor patients in a coma situation and monitor the positions, but as soon as there is a physiotherapist in the team, well, this is usually shifted to him or her. Yes, indeed, there is a rehab team in a well for surgical and burn patients, and there's one PEDS and one nutrition side. This was assessed last year. The physio manager and Pierre went there, and indeed there are cases with major neuromotor delay in a well, and so we wanted to make sure that the team on site can also be trained on neuropediatrics, so that we could flesh out their capacity and their knowledge, so as to be able for them to care for these patients.
To answer the second part of your question, I haven't had this pediatric IPD in neuromotor delays. No, when I was in Katsina, Kano, and Maiduguri, there was none with a neuromotor delay. There was one, and he was a child with severe acute malnutrition. Doesn't mean that none of the pediatric ward children have a delay. It seems that with malnutrition you have more, but for a more general project like in Aidan, in Yemen, there were some physiotherapists for surgery for adults, and we've added pediatrics physiotherapy, and they are following up a few neurological cases and malnutrition cases. And mothers in the obstetrics component, Elisabeth has just come back from Yemen, where she assessed the obstetrics. When you have mothers, you have children, and vice versa. It was quite relevant indeed. Anything else? More questions? Well, thank you very much for these presentations and very interesting discussion. I'd like to comment on what you've said, Emmanuel, regarding the mid and long term, where we could imagine outsourcing this type of activities. That's not what you meant? Speak in the microphone for people who are online. My viewpoint is the midpoint is that physiotherapy is a medical complex patient management, so it has to be made operational internally with us, with shift of teams, experienced people, etc. Well, you know, the clowns playing with children and all the stimuli activities are very important, and this could be outsourced. Okay, then I understand. I was quite surprised when we said we were talking about a subspecialty. It's not only physiotherapy, which is truly a profession in itself. And you will not train people quickly on these skills, of course. But as you've said, you are a pediatrician, physiotherapist. Most of the physiotherapists do not have this specialty of pediatrics. So indeed, there is a tension at MSF when it comes to managing the very acute nature of this type of intervention, plus management of severe acute malnutrition. And this is a recurring question in the nutrition program. It's terrible. It's a reality we have to face. Physiotherapy in hospitals for children with severe acute malnutrition is close to a resuscitation because there is physiotherapy for many patients, plus the specific nature of malnutrition, you know, neuromotor delays up to 5%, plus the retraction cases. So for some years, we've tried to talk about quash neglect. There's nothing, very little literature, very little diagnosis criteria, very basic. And I think there was a physiotherapy neglect in malnutrition program, and it should be part of a medical operational program, just like any other activity. I would agree with you in theory, but I understand that some teams would say, well, in practice, it's going to be pretty difficult to reach out the 25%. And I must say, I'm not familiar enough with the projects. But from what I understand from Vicky, she said we have to find kits to simplify things, to have something lighter, to reach out a higher number of patients. I think this tension has to be made visible rather than say, even though I agree with you in terms of desire for the future, you know, talk about it and have these children. And there was a question about research. I'd like to pick up on what you've said. When you see that at Katsina, initially was 900 beds, 900 patients, we have taken care of the quash children with only 3 physiotherapists by defining the priorities. And outside of the peak season, we may consider also providing care to some of the children with delays. Well, if you have more severe cases and you deal with them today, the not so severe today will be the most severe children in the future. So you need multidisciplinary teams to start prevention at the very first day of IPD, hospitalization. Awareness raising of mothers is such that the prevention is successful now. And then I have a question about research. It's about the way it was presented by the Kano medical referent. He said we would need a research with 2 arms with children to whom physiotherapy is offered, and the second arm, nothing. I don't think it's very ambitious in terms of research, is it? Even though we know what we'll find, it will be research to demonstrate that indeed it makes a big difference when there is physiotherapy. What is a bit frustrating is that we know the result of this type of research in advance, but there is something very acute and fine and accurate, as you know, selecting the children, the most severe, have a prevention, you have models of care to be investigated for, and what type of physiotherapy for which type of patient. So various models, because initially the question was, Well, we wanted to perform research to convince people at MSF that we want to implement physiotherapy, but I think that we should go beyond that and demonstrate other things. I think it's important when we talk about keeping things simple or streamlining. Simplification in nutrition is ambulatory, treat more patients. That's my viewpoint. It doesn't mean that the life-saving emergencies will be set aside. We need to harmonize our terminology when we talk about simplification. Now, regarding task shifting, I have observed the teams of physiotherapists in the field. It's a specific training, indeed. It's a specific profession. Well, thank you. Thank you for this suggestion about research, because indeed, this is what people in operations would need to try and find the most functional solution. I think we'll have to stop here. Thank you to all of you for all your questions, and give the microphone back to Pierre. Thank you to all of you. Thank you, Anthony, also was online with us. It was fascinating, and it's a bit of a pity that we have to stop here, but we will have a panel discussion this afternoon, because we'll be talking about more cross-cutting issues like, scaling up and how we adapt to the context with the professionals on site. And what about the sustainability and research is part of sustainability, and the ideas you've suggested are very interesting, and I'm sure we'll talk about it again this afternoon. We have slightly exceeded the time. We'll try and be on time to resume at 2 p.m. A short side comment. For those who are on site, there are some pictures displayed with a notepad on which you can write a kind message to our teams in Gaza if you want to. Thank you.
Let's restart for this afternoon. So for the first session of this afternoon, we will talk about lower limb amputation and prosthetic with Sajdi Mwala from the 3D program for the MSF Foundation. And we have the chance also to host Abder Banoun, who is working for Humanity and Inclusion as a prosthetic and orthotic advisor and operator. So I give you the microphone.
Thank you, Pierre. Thank you all for joining, and
make it closer.
We'll start. So first of all, welcome our guest from HI, Abder, with a long experience with humanitarian work and also on the prosthetic and orthotic care. So it's a big add to our presentation today. So please, Abder, if you would like to say a few words.
Yeah, thank you. Good afternoon. Yeah, it's a pleasure to be here with MSF and with the rehab team and the medicals to exchange about prosthetics and orthotics, but mainly on prosthetics on lower limb fitting. Yeah, I am prosthetics and orthotics by background. I work as a global specialist with Handicap International. I work with other organizations as well. I am the lead prosthetics and orthotics at HI, and also the focal point for 3D printing globally. Yeah, thank you.
Lower limb and prosthetic is something like MSF been trying, or at least in the foundation, we're trying to explore a lot. So it is a good chance for us to give you an update and better perspective in how we could, tackle this big, challenge and demand within the field. So at the beginning, I think it's good to give like a kind of small, refreshment and introduction about what does it mean to talk about a prosthetic and orthotic. So, and the best one to start is Abder. So please, Abder.
Yeah, thank you. Yeah, I will just make it very short and brief. As you know, we are talking about external prosthetics. We are not talking about some people that are mixing. We have the internal orthopedic prosthetics, but we are talking about external one, meaning that it replaces a limb or part of limb, and the orthosis is just a splint that replaces a function and enhance certain function of body part. In general, let's say prosthesis replaces and orthosis enhance. Next, please. Yeah, and briefly, the journey has started long ago. We didn't discover this recently. It has started at Egyptian time, and this is the latest what we found. It could be even before, and yeah. And after in the Middle Age, at Renaissance, we started also doing some devices, metallic devices, and in 20th and 21st century, we started new devices, advanced the modern and high-tech and bionic devices. Next one. In this picture, I just summarized the history where it has started. You know, in 1,000 years before Christ, we found this at Egyptian Egyptian history, and before that we could find some crutches, and before that, and the history shows that during the Middle Age also we started developing the new concept of making devices with wood and metal, and the last century has really boosted this technology with advanced part and function of the prosthesis. As you can see, in the 50s, we have produced the first what we call the satch feet, the polypropylene foot, which has copying exactly the human foot. And in the 70s, the technologists and industry started making new devices for orthotics to help people to move and to gain maximum autonomy and mobility. In the 90s, the prosthesis has replaced a new concept with dynamic feet, like the sport people can make some records, a good result, and exactly copying and even going beyond the human body, as sometimes we are talking about l'homme augmenté, and you have seen the South African guy, Petrosis, who was running even better than the normal people. And from 2005, we have a new generation of knees, the connected knees, the bionic knees, and this is a revolution. And since last year, we have the first bionic leg, complete leg. We're not talking about knee. It has been developed by a French company. It was the first, it's the first in the world, what we call Sensis system. It prosthesis for low limb starts from the socket, the knee, the ankle are completely connected. And it's smart. The patient even can control it with smartphone, changing the position of the foot according to the shoes. And this is the latest one, and it's a French invention. Next one, please.
The prosthetic and orthotic, as you know, yeah. Right. So prosthetic and orthotic, as Abir explained a little bit for us, really can change lives. And the post-amputation care is really essential. It's not only providing the prosthetic, is also to complete it with a complete rehabilitation program. And this will help the patient to restore independence, functionality, and also for the dignity and the participation in the society. So rehabilitation is really an investment in the long-term recovery, and also it's something essential for the patient. And without it, the patient will face a lot of challenges in the functionality, activity of daily living, and also unemployment and social isolation. So if you look out to the numbers about what we are having in the world now, we are talking according to the WHO that between 35 and 40 million people worldwide needed a prosthetic and orthotic care. And, this is about like 0.5% of the global population. Unfortunately, around 80% of them live in the lower and the middle income country. And according to the statistic as well, like only 50% can have access to the care. So the need is high and also impacting the patient. And on the other hand, also beyond amputation, there is 2.5 billion people require orthotic or assistive devices for a condition from congenital deformities to a chronic disease. And this is a big gap, like, when it's come to the providing care for the patient in need. And P&O care remain a privilege until now, which something, we can see it in different places within the world.
So now here we're going to talk about prosthetics. I say prosthetics and orthotics because it's my profession, but we will focus more on prosthetics. It's a comprehensive rehabilitation care that includes surgical stages and a follow-up and medical consignment. But it's also talking about it involves a lot of logistics, meaning infrastructures, human resources, technology, capacity building. And for that, we need really skilled people. And it's really, this is the main problem we have in the field, that we don't have a lot of trained people in this field. And the main schools and training institutions are in developed countries. And the few ones we have, they are not running as it should. I mean, in general, the prosthetics and orthotics services are holistic. They are more about than the device. It's about people. I remember someone who's he's a prosthetics user, he's an amputee, and he said, "I am not disabled. I am differently able," meaning the device make him able. Without a device, he is disabled. Then we can make people able just with that device. And also, if we are talking about that, if you can imagine that someone who lost his limb, only just a part or just a foot, for the ambulation or to walk, to move, he needs the other 3 remaining limbs to move. He needs crutches, then he has to replace the lost part by using the crutches. Then he cannot do anything when he is moving. Meaning he has to stop, to sit or to stand, to use his hands. Meaning when we are making that small part of an artificial limb with plastics or metal or with whatever, we just free his upper limbs and he can be more productive and he can be more autonomous, as I can say. Next one. Yeah, delivering prosthetics and orthotic services in humanitarian setting is so hard. As I said, we need a big infrastructure. We need heavy equipment, a lot of energy, and usually the orthopedic centers, it's a big factory of artificial devices, and that need trained and skilled people and a lot of time and a lot of time also to train people, because to train one PNO certified one, we need at least 3 years. Usually it's 4 years in developed countries. And we have also a lack of patient follow-up to access the services. We have also a constraint of safety and security to for the patients, for the users to reach that orthopedic or rehabilitation center. Usually in the context where we work, in some countries there is only 1 or 2 by country, and they are in the big city or in the capital city. And these people who already have a problem of mobility, and they have to move for hundreds, sometimes it's thousands of kilometers, that needs people to accompany them, a lot of money, a lot of transport means. And for this, we just thinking how to improve, to access, to get closer for this patient to go reach them on their place, on their home place. Next one.
So for MSF, on the top of all the challenges that mentioned by Abdel, MSF has a really strong tradition of providing a very surgical, medical, mental health and nursing and rehab care, on their, context where they are deploying. So orthotic and prosthetic always remain difficult to apply. Especially in an emergency project, for example. And also, as Abder mentioned, the shortage of a trained staff, the workflow between surgery and rehabilitation, also needed for a big infrastructure, is also another, challenge that for MSF. Again, if you go to look to all the trauma centers that MSF has nowadays, they are getting low and low. The number of amputations in those traumas are less and less. And this make, launching and sustaining high specialized P&O services is not a practical priority for MSF. But this will lead us to questions that need to be answered, or to give us more questions to answer, as Pierre said. Sometimes when you ask questions, you will get an answer, the other you will have more questions. So we will try to, through our exploration, how we could apply the services within MSF, try to find solutions for that within our activity. But at the beginning, we need to ask the question, like, how can humanitarian actors bridge the gap between the urgent need and limited resources? Also, what models of care to ensure both emergency and responsiveness and the long-term sustainability? Because we're talking about like prosthesis and orthosis, follow-up is really one of the big concerns that we will have, especially with the pediatric cohort. Usually they grow up every 6 to 8 months. We need to change the socket. They get taller, they get, they gain weight, they lose weight. So there is a lot of changes, and this need to be addressed. And also it's a challenge. You need to find a way to tackle it. Also, how innovation, when it comes to the new updates, like new technology, can scale up services while maintaining the quality and also the safety for our patient. Because we don't want just to try out new things on our patient without making sure that it's safe, it's clinically valid for our patient. So this is some of the questions we will try to answer with you, and maybe at the end we could rediscuss it again to see how we can really find a solution for that. Abdir, please, 3D printing.
Yeah, thank you. Yeah, okay. 3D printing is really changing the game. As I was saying before, it's difficult for the victims of the MPTP to move from their homeland to the orthopedic center. This is the big challenge. Well, it's one of the biggest barriers, in addition to economic barriers, security barriers, and plenty geographical barriers. And we at HI, we developed the concept, what we call it, TERIFA, it's tele-rehabilitation for all, meaning we use the ICT technology or to go as closer as possible to the patient. We use it as a bridge. We use this innovation as a bridge to connect the patient to the service providers. Then it breaks these barriers, and it's very light. We can go with a backpack to the villages to reach those people, to scan them, and to click and to send the file directly to the orthopedic centers or the service providers. And this is what we use. The 3D, there are plenty of evidence that 3D printing or digital approach shows that it's true that it's very new. It has maybe 10 years since it has been used in rehabilitation. But now, every day, we have seen that there is documents, there is evidence, there is shows that this digital approach is accepted by the professionals, by the users, the patients themselves, and by also the policy in each country. And now we in 3D printing, if we are talking, we have 3 axes. We have the axis of all this equipment, the printers, the scanners, this hardware, and we have the other axis, which the software, the design, the scanning, the slicers, and the third pillar or the third axis is all the materials. We are talking. Is it which plastic? Is it resin? Is it powder? There are plenty of technologies. These materials and polymers are now valid. They are accepted, maybe even in France by assurance. They accept it. They reimburse it. They use the filament charged with carbon fiber. Now it's accepted as for prosthetics of lower limb. It's strong, and universities are working with. At HI, we work with INSA, Institut National des Sciences Appliquées, with a lot of studies, a lot of pilots, to show the evidence that the digital or 3D printing approach it works in text. For example, we have here some example. This is a 3D printed socket for transtibial amputee. It came from Uganda, and this one it's un releveur de pied. It's ankle foot orthosis for clap foot, for drop foot, for the child. It's for real patients. These are the devices we are providing, making in the field. Now it's not experience. It's not a pilot. It's reality. It's a new way. It's another way how to make devices. It's not leather, it's not wood, it's not metal, it's not resin. Now it's 3D printing. If we are going to talk about solutions in this innovation, we have plenty of big companies or big actors in the world. We have, as I was saying before, a Proteor is French company who has developed what they call digital suite in piano. They have the full package from scanning, digital designing, and printing device. And we have Instalimb, which is a Japanese, I don't know if I cannot say, is it startup, is it NGO? It's a mix of both. And we have Ogani, which is a Belgian company, startup, starting some projects, yeah, in Kenya, in Congo. They want to scale up. They try to work with us, but we have the expertise. I think we don't want to do, and in addition to that, we will show you in this next one the HI journey or experience. Is I can say the roadmap of our experience that has started in 2016. I think MSF has started in 2017. At that time, yeah, people, they don't believe in it. It's kind of science fiction at that time. People say, no, it's kind of, you just want to play. But now, no, we had the vision where we have to go. And we started in 2016 by a small pilot project with 24 transtibial prostheses in Mali, Togo, and Madagascar. And after, in 2017 to 2019, it was a real study, a research study with Belgian University, Thomas More University, that comparing traditional method and digital method on the same patients. We fitted 100 patients with lower limb orthotics for each patient, trying both, in order to compare really the real cohort, the same group, comparing both. And the evidence was showing that there were 3 studies. Social one, it was the acceptance by the professionals. It was accepted. In the beginning, some physios say, no, we don't want. And after they said, we want to be in. And PNOs, they accepted it. The patients themselves, the parents. It was in social acceptance. Technologically also, we have a good result. It was at that time, in 2017, it was almost 60% of success compared to the traditional one. And this was done with a university. It was good evidence for us in order to allow us to go. The first one was prosthetics, second one was orthotics. And in 2018, we did also 50 transtibial prostheses in conflict context to change also the context. It was in Syria. It was really difficult because it was completely locked. For northeast Syria, we sent some prosthetics. They were being lost in Erbil, and plenty of logistic constraint. And we said, no, we stop producing from Europe. And in Uganda, we started putting even the printers and the scanners and the international staff in the field, in a refugee camp in northwest Uganda. Now we went in chronic crisis. It was in conflict. Now it's chronic conflict. And the project, it's still running up to now, the one in Uganda. And in 21 to 24, we went to Rwanda, still the same with the refugee camps, but another project with Center of Excellence and Biomedical Engineering of University of Rwanda to explore how to work with academic institution in Africa directly. We try the technology and we try how to implement also in the context. And from 23 to 24, 25, Now it's Ethiopia and in Somaliland. We have 2 projects. At the end of this year, we will start a new project in training institution in Yemen. It will be in piano school that we will introduce 3D printing then in order to don't need to train people. We just do it. We kill the ill at the root, at the origin. Meaning all the new pianos will be trained on digital approach. Yeah, I think this is for you.
Yeah, the 3D technology could answer a lot of the questions, the challenges, or like the space and the supply chain of the material and all of that. It can be a good, a solution also to an option also for working in humanitarian, and it's proven that it's clinically valid and also safe for the patient. And there is a lot of options in the market with different companies are working on improving and also re-innovation, everything related to the prosthetic as well. Also HI experience when they did a lot of different projects that were trying to apply this, and it was a successful one. But the question is for MSF, should we take this opportunity to try to invest more in not only saving lives but restoring life and giving more hope for the patient and give them more chances to be independent and function. So MSF has a lot of legacy when it's come to the emergency and surgical care and and also rehabilitation and medical care in general. And on the top of that, we have a deep operational reach. We have a trusted patient, relationship, and also we have our own 3D printing expert and experience where we develop it through the years since 2017. So for us, which is missing is mainly our capacity and our experience when it comes to the prosthetic and orthotic. And here we are trying to raise an idea about how we could tackle this, and the answer to that, it will be the next thing about how can we do it with other NGO like HI, they have a deep expertise, and why we need to do it. So Abder, if you could elaborate more on this part.
Yeah, thank you. Yeah, that will be the ideal for us. Yeah, we really wish that to collaborate together, because I think we are the only 2 organizations having 3D components. You are doing for the face mask and for the upper limb, and we are doing it for lower limb and even the trunk corsets. And for us, yeah, we have experience in Middle East and in a lot of in Africa in 3D printing. In Amman, we have a small workshop, what we call it mirror workshop. Mirror meaning to see from the other side. It was done to support remotely the mission in northeast Syria. We couldn't have access. We were just providing and guiding people remotely on with the connected center with plenty of webcams. Even we train people. We have small how we show them how to make device prosthesis, and they can see it from the other side on real context. And now this mirror workshop will be used for Gaza remotely. And we hope that maybe you have your digital clinic there, and if we can merge both of them in order to create a kind of a hub in Amman. Amman is a good place. It's stable logistically. It's accessible, and it can cover plenty of the conflicts in the region, from Yemen to Iraq to Syria and other countries. We wish, as HI, we have vision to open what we call a reference center. It's not a referral, un centre d'expertise. One or two, one in Africa, East Africa, one in Amman, where we can have the best place where to show the good practices and to bring people to train them also, to have 3D printing, to have other techniques. Let's I will not speak about other therapies. For example, we have this new approach I will show you here. When we are talking about 3D printing, we print only the socket. This is the only part we are printing. The others are commercial part. The study I did it myself with the University of Lisa. We reduced the cost of transtibial with 20%. But as you may know, HI has a recycling workshop for second-hand prosthetics in Europe. You know that in France, for example, we produce around 12,000 prostheses, high-tech prostheses a year. And for your information, each patient has one every 5 years, one new one. And it's single use. We cannot use any part of it. They have to throw them. And we are collecting a couple of thousands of these prostheses. Yeah, I am the project manager of that. We recycle, we recondition all the parts, and we send them to our 3D project in order to reduce the price. The study we did reduce the cost of transtibial prosthesis with 83% of the cost, meaning the cost only the socket, the others they are for free, or only it costs the shipment.
I think we reached to the we exceed the time, so we have to conclude. If you could please.
This prosthesis exactly it's 3D printed one with a reconditioned component, and what we are using in the field is a high tech. It's the most expensive component, and they are sent to the field for free. And that's what I can tell you. Sorry. And collaboration for MSF to show what we call it frugal innovation. It doesn't mean that we have to be high tech, but this one is very eco-friendly. Just if I summarize 3D printing, we save without this recycling. We save a plaster because to make a device we have to need to cast. We save water. We save a lot of materials because to make a socket or device, we just mold and we throw like 50 to 60% extra. Then with 3D printing, we just print exactly what we need, and we don't need to cast. We don't need to make plaster modifications, and it's really eco-friendly. We use lesser equipment, lesser infrastructure,
and more accuracy. Yeah. Just to conclude, the last thing is about Amman Hub. It's a potential idea. We would love to do something like a center of excellence, which we can do digital innovation. We can be like a big support for the region. We propose this in Amman to have all the surrounding areas with a big need, so we can have a flexible multi-delivery model, as we can do scanning, designing remotely, even printing remotely. So there is different model of delivery. We can adapt. We can train people. We can train them remotely. We can train them in house. We can train them in the countries, and pooling the expertise with the HI will allows for better quality and sustainability as well. And at the end, I would like to give a question, and we'll open the discussion after that. Is the MSF HI collaboration could enhance access to the prosthetic care? And thank you, and sorry for taking over the time. And now we would like to open for a discussion. Thank you. Yes, please. Yeah.
Thank you very much for the presentation. I have a quick clarification question. You introduced Sajdi saying, in fact, this is not a priority for MSF operations. because the number of also people who lose limbs is decreasing, and then you use all sorts of constraints. You listed out all the constraints that we meet in a lot of places that make this kind of project complicated / impossible. So my question is, I mean, is there some kind of demand? I'm not talking about needs, right? Because this need argument is too vague, too wide, and too kind of an authority argument that, you know, there's always need for something to be done. But at least, is there some level of demand from some projects within MSF for this kind of prosthetics? And then, or to be, you know, like the center of excellence that you speak about would be directed to provide access to these prosthetics to patients, right?
The question is very good. Yeah. When I put all this, you know, challenges, and I put all this, you know, explanation about like MSF, even, you know, we talk about like the projects, number of projects with trauma and the number of amputation patient we have in our project is just to save the time from explaining to me that, because this is what is the operation needs, you know, when it's come to the field. But when it's come to the reality, as you say, like there is a need. About the demand, yes, there is for example, Gaza. I think you hear about Gaza. So the number of amputation is really very, very high. Places like Syria, after, you know, the regime is gone, and now there is a whole medical infrastructure is collapsed, and the services is not really very well implemented. Some NGOs manage to do that, but it's still the services is not stable, and there is a lot of, as you know, there is a lot of, you know, fields need to be covered. So when I say about like the regional hub, I'm not saying like we need to open in every, like, you know, project the same classical way of a prosthetic and orthotic center like the HR used to do. The idea is to have something very flexible. So the model of care, we can decide it according to the need from each country. Each country, they have the need in a different way. Some countries, they have a very low P&O, you know, staff. The others will have less workshops. The others will have less, you know, don't have material services. So each party have a different, you know, challenge and a need. And the idea is to have something we could work to improve the access of the prosthetic and orthotic care in the region by providing a training. Maybe we're providing some equipment like printers and scanners, providing remote support, which the people can do scanning using this 3D new technology, all the innovation. We can do, for example, the scanning in one place. If there is no enough skilled prosthetic and orthotic, we can do the designing remotely in different place like Amman, and then we can send it back and print it there or print it in house and do assembly there. The idea is we need to find more access to our patient, more proper follow-up. And MSF has a long experience when it's come to the surgical rehabilitation and mental health. So we are looking up is not providing only a single service, because the prosthetic and orthotic are not something like providing a shoes. So you just distribute it, and this is something very wrong. And I think the HI will agree with us, because you are not providing only just the prosthesis and give it to the patient and he will go home and that's it. No, it's need a long rehabilitation and need a proper follow-up, wherever it's from the beginning. Surgical assessment if the patient is really ready, a proper preparation by a physio team, and then you need a mental health support, because the patient will have another issues. You know, losing limb is not something easy, you know, and you need to make the patient go back on his feet to be independent and also functional as well. So the idea is to have a solution can really match each country according to the needs in each country. This is the idea. I don't know if I make it clear, and please.
Me, according to the needs, I know that the needs are increasing. Or evidence are showing that diabetics, arterietics, road traffic accident, wars, conflicts, the population global is growing, meaning the figures, they are growing with it, and much higher than what we are expecting. But the amazing the rehabilitation centers, we don't see that people, our countries are constructing. No, we see that lesser, and all in these countries in the conflict, they rely on NGOs. Definitely. Just yesterday, we received a demand from surgeons, volunteers for Cuba that there is no orthopedic center. Every month we have a request. The demand, we are saying, if there is a request, for us, we have a request. And I guess it's the same for MSF. Maybe if it's not, I don't know.
Yeah, for MSF, it's a little bit different because we are not well known as a P&O NGO, so this is why we don't have a direct, but we have indirect. Like our patient in Amman, for example, when they go back home, if they have a prosthesis, also, yeah, they need it. In Gaza, for example, so the patient who are coming to our hospitals and they have amputations, they also they need, I think in Haiti, the same thing, we have some requests. So yeah, but at the end of the day, we are not well known as a P&O organization, unlike HI, what they have. So when it's come to about the demands and the need, yet it's there.
Yes, thanks a lot. It's very nice to see the like double presentation, like using the skills and expertise of each other. So I think it's because sometimes we do the MSF bubble and Oasis, but I think it's really nice to have you both. Maybe I misunderstood, but I think I read like 1,500 patients equipped in Tigray, like from the Ethiopian conflict.
It's just starting, that's the project.
Okay, that's the, and so because that's quite a significant number, you said 24, 25, so over a short period of time, do you produce locally or?
We had just few issues of logistic, Ethiopian government, it's really tough and we are struggling and the materials are there. To tell you, this is, we don't need to hide it and the materials is getting in and we have all approvals. We will have a delay, but the project is there. I mean, the stuff is trained, some materials is there. They just hold some key equipment and it's going there. And it's the same for Yemen.
My question then is related to the bottleneck and how MSF could support or work in like synchrony, like symbiose, I don't know in English, but because we have a bit the same patients, not necessarily at the same stage, or how do you see the potential synchrony?
You do the first part of, the life-saving, the amputation, etc. And we have the experience to do the second part, and maybe our collaboration will make a sense because, and just for your information, it's exactly like a burn patients. It's very long process and it's very costly, and usually you say one process because our donors they take the whole amount, they divide it, but one prosthesis, one device, it's 10, it's 20 physio sessions. They don't see that, but it's long, and the amputee is amputee for life also. A child, he needs a new device every 6 months, 8 months, 10 months. And we have to renew. And this, unfortunately, as I said, we can make them able as we can leave them disabled. This is what we can make a real change. We have a financial crisis. I know all organizations are facing the same this year. And unfortunately, we have a good experience in that. And we have huge demand, and we cannot satisfy everybody. I said yesterday, and which is true, and almost every month or every 2-3 weeks we have a new demand. Supporting, but we have limitations, and sometimes it's really tough, hard to say. Unfortunately, we cannot help.
Yes, there is few questions from the audience. So one of the questions is coming from Yemen, asking if this kind of technology can be used, but I think you can answer that, Abder, because you were starting to mention Yemen. So that's about prosthetic, mainly we're talking about upper limb and lower limb prosthetics. And then there is a few other questions. One is from Nigeria, asking if how long does it take in normal circumstances to do this kind of prosthetic and I will add by myself also the follow-up care. And another and last question is that's saying that it's a great job, so thank you for you both. But how are you innovating in capacity building within the countries to improve the sustainability? So 3 questions, one about Yemen, the second one about how long does it take in normal circumstances, and third one about innovating in locally capacity building.
Could you just repeat the one for Yemen?
Sure. So asking if we can use this kind of technology, thinking about 3D technology for lower limb and upper prosthetic.
Yes, in Yemen, actually, we are supporting a bachelor degree in prosthetics and orthotics in Sana'a. Bachelor degree, it takes 4 years, and we are just in the middle. And the printers are going to reach the country at the end of the year. And the first pallet of equipment, I did it myself. I am sending myself with my hands 2 pallets of materials and filaments to go to Yemen to support, because we built 2 orthopedic centers, one in Hajjah, one in Hodeidah, and those trained staff in school, they will be dispatched in those. They will be already skilled with this digital approach. And after the second part, we'll maybe just to equip those centers with a printer and scanner, which is very, very light. If they are skilled from school, it will be much easier. For us, our digital approach is really a real bridge between the users and the providers. One of those studies I did, in fact, the added value of digital approach, when we scan, we need only few seconds, same seconds. Can make scan for 5-10 seconds, not more. Imagine the time it takes to make plaster casting, talking maybe half hour, 1 hour. Plaster modification, it takes hours. We can make it in 10, 15, 20 minutes designing on the computer. And after, it's just a question of click on the printer. It does the job itself to print, and it frees the technician, and he can go do other things. Then the total manpower that we need, the physical presence for the technician is just 70 minutes for digital approach, when we need couple of hours in the traditional approach. Then the printer can work day and night. When the technician has launched the printing, he can go alone and to come the day after found it ready. It can work at night. It's a very big advantage in this technology, and the technician can do something else. I mean, he's technician, he's clinician. But in the other, the traditional one, he has to be doing only one task. This is what we can say on that approach. I don't know which the other question.
Sorry. The last question was about how are we innovating in capacity building in the places where we are working, like what we do in terms of capacity buildings to the local community.
First, we have to train people, the professionals. I want to add something I forgot. This digital approach, we have one condition. It has to be used by the clinicians, trained people. Not anyone who knows how to play with the software can make the device. It's working tool for the clinician. I'm talking clinician, someone who has a diploma from the school. Not anyone who is a geek on the computer or digital can, because you're laughing, because we have witnessed a lot of initiatives that we don't accept it. It has to be used by real professional and clinicians on that. Yeah, I think the only thing we have to train people first and to lobby at local authorities to be introduced in the national health system also, because if it's not accepted, we cannot do anything. This is the two conditions, and it has to be also incorporated in the best way within existing health or rehab facility. We don't need to build a new one, otherwise it will be more costly. I hope that I answered.
Yeah, maybe I can ask a question. So you were mentioning like all the different challenges going from logistic challenges, the material, the availability of the staff, and to have like trained staff, the budget that represents. There is also, in the different crises, we were seeing that there was also a lot of initiatives, a lot of different actors. So how we should navigate into that, and how the let's say the possible collaboration that we can get between the two association, HI and MSF, can be included into this this response.
Our both experience and also privilege we have in the field, because we both organizations and mainly MSF is well known, is well integrated within humanitarian context. I mean, everybody know. I mean, even the local authorities, they trust the organizations as professionals. Maybe no need. You can do it, but no need to duplicate. I mean, the same job, and it's the same for us. We in some health issues, we say it's not our expertise. We keep away and we let it for the organizations. I think maybe the best one is to first start one initiative, like in Amman, as when we see it works very well, we can after duplicate it, faire tâche d'huile, and after in the other contexts. And yeah, this is the first step, maybe to build a pilot project or a common pilot project in order to see how to articulate it, to work together, and to make it better, efficient, because if we join our forces, I think we can make it definitely much better.
Yeah, if allow me to add on the topic, because it's a very good question. When it comes to the crisis, usually in places like Gaza, there is a lot of people who would like to provide, and whether they are an NGO or private donors or any initiative. And there is a big, ethical concerns about like what type of services they are providing, how safe it is to be given for the patient. And I would like to give an example about Gaza in particular. At the beginning of the war, like after a while, when the number of the amputations start to be higher and higher, there was an initiative was started by the King of Jordan, and this initiative is try to provide prosthetic care for the amputees in Gaza. So he asked one of the NGOs in UK to follow up on that, to do a kind of a coordination with the Jordanian Army Health Services. So they came to MSF, they came to our offices in Amman, and they opened up this topic, like, we would like to have a kind of a service, like a prosthesis, and they mentioned one company name. And I was at that meeting with Dr. Rashid, our regional surgical referent, and we gave him some concerns as a MSF, because for us, first of all, before providing a prosthesis, you need to make sure that the patient is really fit and ready So there is a surgical assessment need to be done, because at that time there was no guarantee that the surgical procedures were done for those patients are perfectly done. So it needs maybe to be a revision. If he has any complication, if he's ready for the prosthesis, he needs a preparation from the physio part about the prosthesis itself. If there is any follow-up when you give the prosthesis, what type of prosthesis you are providing. You are talking about a prosthesis can be done in 1 hour. I don't want to mention the name of the company, and they are providing also a silicone liner. Silicone liner, you know, if you give it to the patient, and Abder, you know more than I do, and the patient get used to it, he cannot go back to the one, like the basic one, without a silicone liner. So those things or those concerns, usually a big NGO like HI and MSF, when they are interfering in such a crisis, usually we follow, you know, an evidence-based practice, an ethical approach, and also something clinically valid, and we don't harm our patient. When it's come to different NGOs, small initiatives, this is not guaranteed. There is a lot of 3D printing companies now. They are trying to reach Gaza just to send their product without any testing or valid testing. The technology is there, is approved, it's done, but you need to do it in a systematic way and standardized way that will follow the recommendation of the manufacturer or the service provider, like one example, Brottier. So to make sure that the quality is guaranteed, it's the same that when they got the ISO for it. So that's the challenge here. So you need to step in as a big NGO. This is a big burden or big responsibility on MSF and HI, because we are a big NGO. We should step in, otherwise another NGO will harm more than they can benefit the patient. And at the end of the day, they will come back to our facility. Like then this guy, the one who came, you know, sharing this initiative of the king to MSF, he didn't like what we said, and he started the process. And the hospital army in Gaza start to provide prosthesis for the patient. They end up in our physio clinic, in MSF physio clinic, suffering from a lot of blisters, you know, and pain in their you know, legs. And I think something, you know, MSF should step in here, because as a big NGO, it's a part of our responsibility. Yes, and then when HI started their own project, it was also a big challenge, because they couldn't able to enter the material because it's not COGAT approval. So the idea is it's a big challenge and a big responsibility, and see a lot of resources. Having collaboration between MSF and HI, it's really something will ease the burden on both of the NGO, and also will be in the benefit of the patient, to make easy access for those patients, and also to help to integrate the 3D printing technology into these local communities, which will make the P&O services very accessible to the patient, and also this will provide a longer follow-up for the patient. And there is a big mandate that HI do, which MSF we don't do it a lot, which is the development. Because usually we go, we intervene, we do a direct service. HI, they have indirect service, which they build the capacity of the locals through MOH, through universities, and this will give more empowerment for the society, and this, on the long term, reduce the responsibility of the NGO to continue to provide a direct service. And this is a good, smart thinking to, instead of being like, you know, in a country for years, providing the same service without working on building the capacity of the local communities and the local staff. So this is the point that we would like to tackle by our, you know, proposal for the collaboration with Amman. In addition to that, 3D as a technology, it's a tool. Usually you use it according to the need. In Amman, we started with the upper limb prosthesis. We added to the top of that the rehabilitation, and now we have a very successful one. We use it to produce the TFO, which was a big, you know, remarkable change when it's come to the management of the burn in the neck and the face. And also there is a surgical prints, the assist devices. So the 3D technology, you use it according to the need, and maybe there is more needs is coming. Like recently, we received two requests. First from Gaza, they wanted to to print external fixator, you know, and this can be visible. Having this joint experience with HI to help us to innovate and to have a broader application for the 3D, which will serve a lot of our patients and our projects. Any more questions?
Yeah, I'll take one last question. Please go ahead.
Just a naive question, but ICRC, which I think is the other big provider or thesis provider, do as well 3D printing?
No, they don't do. They have only a partner in Ukraine.
Okay.
To do just the shell, the shell, say cosmetic. They don't do. They didn't embrace this technology yet.
They're still on the traditional prosthesis.
Not only traditional, even their own. No, I worked 14 years with ICRC as a project manager. I am defending, but they have their own technology. What they call it polypropylene technology. It's low cost.
Another technology.
Another technology. What they call ICRC technology, but it's polypropylene technology. They developed their own technique. And they stick to it. In some countries, they are obliged to use the high-tech one, but they are hesitating
to go towards somehow.
To be honest, they have to.
Okay.
There is no way to escape. It's just question of time, and they are still resisting. Because it will be just a new tool. It will be first introduced in every rehabilitation center at small scale, and after shifting gradually. And we cannot avoid it.
Okay, thank you.
Thank you, Adel. Thank you, Sajdi. It was a great presentation. And if we well understand, thanks for the proposition. And if we want to move forward for the community of amputee people, we need to join force at some point and find innovative way to find solution for them. So thank you for both. We will take a small break and we start at 3:20, so in 12 minutes, with the last round, which will be the round table for discussion. I'll see you there.
Ok, eh bien, bonjour à toutes et à tous.
Good afternoon, and welcome to the last session today. That is a panel discussion on the operational and medical challenges on rehabilitation implementation at MSF. I'm very pleased to act as a moderator. I'd like to thank Aurelie and Julie for having invited me. My name is Matthieu Guemann. I'm a physiotherapist, and I am a professor at University of Orléans, and I'm the president of the French Physiotherapy Society in France. And in partnership with the foundation at MSF, we work on various projects. So thank you again for having invited me now to start this session. We have a panelist here in Paris and somebody online with us. We've prepared a series of questions which will be guiding us through this hour of discussion with you. We'll start with a presentation of all our panelists. I let them introduce themselves and ask them to report about a rehab project they've worked on and what was the challenge of this project. You have the floor.
Bonjour, donc moi je suis Marc Schakal, responsable des
My name is Marc Schakal. I'm the head of the cell in Dubai, Middle East, in charge of Syria, Jordan, and Yemen, and partly Djibouti. So we do have hospital programs in Haidan, in Namir, in Yemen, reconstruction, plastic surgery in Amman, a hospital for severely burnt patient in Atme, Syria. And in addition, we have more general medicine projects in the north of Syria. Shall I give? Okay, My challenge, I thought I would be talking about what the physio network in Amman, which is not well known, a model which was designed some 10 years ago, approximately 2018. The Amman reconstructive surgery program is not only surgery program, it's also for mental and physical rehabilitation of the patients who were the victims of violence and of weapons in general. And physiotherapy is part and parcel of the treatment and plays a very important role for the functional recovery of patients and for them to restore the mobility of the injured limbs. And up until 2015-16, physiotherapy would stop when the patient was discharged. But we realized that there was a need to ensure some follow-up treatment once those patients were going back to their home countries. We have patients from Iraq, from Yemen, from Palestine, and also we have a few from Syria. So we have physicians in our network who refer this patient to Amman, and they will be in charge of monitoring the patients once they are at home. And this patient monitoring and follow-up would be limited to what the medical team from Amman was asking them to do. But we felt that there was a need to be a bit more specific about functional recovery, because a patient would spend quite some time at home before coming back. So the physio network was in charge of the follow-up of those patients once they were at home. So remotely, we've developed this kind of a remote follow-up with the self-exercise that the patients were supposed to work out, you know, showing some exercise via photos and videos. And this has helped to bridge a link between the home country and the information feedback to physiotherapists, surgeons, and the admin department in Amman Hospital, so as to reorganize the trip back of the patient to Amman for treatment follow-up. This is a model that we have reproduced. We started to have it in Iraq. We had a Baghdad rehab program at that time, and we are reproducing it in Yemen and also in Palestine. There is one person who is the coordinator of this tele or remote physiotherapy. And I think it was interesting because it has helped to improve the follow-up and the functional recovery of those patients. Now, the challenges are many. The ambition was to grow with various networks to find relays on site. It was more difficult. The relays were not always present. Quality was not always up to expectations. And we also needed to convince the health providers of the great interest of the added value of physiotherapy for those patients, which was not always that easy. Next. My name is Guyguy Manangama. I'm a deputy director for Ops. I'm a physician myself. I'm a medical doctor. I was at the emergency cell. I have worked as an emergency field coordinator and deputy the cell. Now, because of my various job positions, I've had quite some experience with physiotherapy. We haven't talked about physiotherapy in emergency settings. And that's something I have experienced myself. I was a medical coordinator of emergencies in Nepal. There was the Pakistani army, there was evacuation of the staff, and we were briefed so as to provide a surgical response. But in the field, during the exploratory mission, we realized that what was necessary was post-operation management, including physiotherapy. So we had to redesign our strategy. So instead of staying in the mountains, we went back to Kathmandu, capital city, where we've developed a physiotherapy rehab center with the physiotherapist. Another experience is recent in Ukraine, where we started our operations, and here again, little room to be next to the patient's bed or in operations. And in post-op, they needed some physiotherapy. So physiotherapy is of an increasing importance in our operations. So regarding the challenges, since I've also worked in Haiti, and I just coming back from a visit in Haiti where I've met the teams in Tabar, and the patients, well, after what we've heard this morning about patients' autonomy and dignity, the fact that it helps them to go back to normal social life. If they're not helped, they feel useless. And in a country where there are terrible difficulties, it is helpful to have rehabilitation. But in a crisis setting such as that of Haiti, there is the problem of access for OPD, for patients to come back for follow-up of their treatment. There is a huge rate of no-show of patients. And in addition to the security problems, there is a social aspect also, that is the capacity of patients to come back for follow-up. So it has encouraged the team to find other solutions, mainly via decentralization. But then how can you provide training at the peripheral level? So all these strategies have to be considered so that we can work as close as possible to the patient and provide the best possible access to the patient. So the challenge that I see is the question of access in our settings. My name is Aurelie Godard. I'm an anesthesiologist, and at MSF, I'm in charge of the intensive care. I work at the medical department, and I'm the co-clinical leader that does include surgery. And I've had the pleasure of meeting Pierre, Julie, Lise, Elisabeth, because of the nature of these programs. Those people are the pillars of the physio team. Physio started to be factored in our missions after orthopedic surgery and treatment of a severely burnt patient. Now it's present everywhere because there are purely medical needs, but also it has a particular place in terms of care to the patient. It's not invasive care. It's one patient for one healthcare provider. That's very valuable. And I think that you play a very important role with the patient and in the team. And the challenge, I think, as we've said quite repeatedly, is how we make this possible for the greatest number of patients, because we've realized that it was to their benefit. And I remember COVID in Iraq. Pierre and Julie and I were on WhatsApp. We were providing, some respiratory rehab during an outbreak. We ended up having many more patients. Marc will remember many severe patients, and the response was an MOH MSF response, which was not easy. And we had physiotherapists from the government who had all the good intentions, but their practice were far and remote from what we do, because we only provided respiratory rehab and a medical background, which is not the same as ours. And you ended up using fiddling around because it was difficult to find an immediate response. Pierre was on site for the BMRC, then the physiotherapist plus remote support, and some expats who came also. So we tried our best to help the patients in spite of difficult circumstances. And once again, respiratory disorders, which was not related to earthquake or surgery. It was quite unexpected, I must say. It made a huge difference for the patient ultimately. So physiotherapy could be everywhere. And since I'm so involved in intensive care, I will go and visit different settings, but in Oma Bay, in Kano, we have people who've had strokes or many different conditions where physiotherapy is something that could be provided by the patient's bed, which will also link up the life of the patient with a future outcome of this patient in their day-to-day life. And you are the ones bridging the link with the patient. So it's a different type of timeline, and it's a cross-cutting issue. I think that we've converted the trial regarding severely burnt patient, but for other conditions, this is still under construction and work in progress. My name is Evgenia. I'm a deputy of the cell for Nigeria, Haiti, and Afghanistan. And before that, I did work with Marc in the Middle East cell. And I think I've seen more or less all the cases of physiotherapy, working with all our friends from the foundation. Thank you very much to all of them, because they're always readily available to be involved in some projects, since many issues have already been covered today by my colleagues. I can maybe say that there's one topic which is similar to what Aurelie has mentioned, which is a different timeline, different implementation of physiotherapy depending on the type of project. You've seen already that, as Marc described, there are projects where we can invest, have the means and the resources, and we're not only in patient mobilization, and we can go up to help them to have an opportunity to find a job after they've gone through our rehab program. And as Guyguy said, we've restored their dignity and they can find a place in society. And for those for patients with malnutrition, we often think that we will no longer see these patients anymore. And at each step of the project, you know, there's a starting point, and we try and see how far we can go. And the further we move, and the more we will see patients. And in Amman, occupational therapy plays a very important role and was introduced recently. Now, what is it that we're going to do with all these projects? How far are we going to move with those projects and be as close as possible to the specific needs of each and every patient? needs that are very different from one patient to the next. And another very important topic is the fact that physiotherapy, because of their very job in the project, would spend far more time with the patients than any other healthcare provider, any healthcare professional. And we've had some progress in these patient-centered programs in the package of program coming from our physio colleagues. I'm thinking of Yemen, where for 2 years the physiotherapists have asked for mental health to be introduced because they were the only ones actually speaking to the patient, understanding what was happening with the patient, and they were successful. And they implemented a mental health program thanks to the call from physiotherapists because they have a privileged position, let's say. They're very close to the patient, spend a lot of time with the patients. They listen to the patient and take advantage of this feedback they get from the patient about the lives of the patients and help us in improving this patient-centered approach.
Bien, on te laisse finir le tour de table.
Okay, Alain, up to you. Thank you. My name is Alain NGamba. I'm medical coordinator at MSF. And I would like to tell you about some missions where we've had some physio in Central African Republic in the General Hospital. We already had some activities with some patients, and in 2020 I went to Haiti. It was at a higher level with 3D printing. Then I went to Ukraine, and I won't repeat what Guyguy has explained. We had a more sophisticated package where we included mental health, rehab, and patient management. And I think that here again, the physio team played a very important role, just as Evgenia said, because the physiotherapists were spending so much time with the patient. They knew much more about the pain of the patients, so they have demanded that we would reinforce the pain management part in this program. And then I went to Yemen, where pediatric physio was introduced as well. Rehabilitation has changed in a positive fashion, I think, with concrete activities and services, new services provided to our patients. But there are still some challenges that depend pretty much on the patient and on the awareness raising of local communities so that they will understand the relevance of the service we're providing and the need to ensure continuity of care, because we have a lot of patients who are lost to follow up. We want to provide the best possible care. And in addition, there is another aspect, which is to stay in contact with the patients as long as we can. Particularly with the patient-centered approach, we can improve this. And I think we should work further so that we have a better continuity of care and make sure that they have the resources to maintain the care. So these are the challenges that I have identified. And if I were to compare with the physiotherapy that I've observed, huge progress has been made. So that's what I've observed up to my position as a medco. Thank you.
Merci Alain, merci à tous pour vos témoignages un petit peu qui viennent illustrer et
Thank
compléter ce
you
qu'on a
very
vu
much to all
tout
of
au long de la
you.
journée. Donc
This
retiens
does,
ça pour dire
in
qu'il
fact,
y a différentes facettes de la kinésithérapie, de la
gives us
physiothérapie.
a
On a l'aspect très
comprehensive
transversal
image
avec la
alongside what we
physio pour
heard
tous,
this
si
morning.
possible. Et puis on a
So
vu aussi une physio
physiotherapy,
d'expertise, une physio d'innovation avec des terrains très
an
spécifiques
expertise
en
know-how
pédiatrie,
in
rééducation,
pediatrics
soins
or
développés,
for
santé mentale.
amputees or burn
Donc il y a
patients
énormément
or for mental
d'aspects.
health
Donc
or general
j'espère qu'au
physiotherapy.
bout de cette journée, tout le monde est
So
convaincu que la physio
hopefully,
devient indispensable
I
dans,
hope that by
dans le
the end
soin,
of the
dans le
day,
parcours de
all
soins
of
du
you
patient.
are going to be
Et puis vous avez relevé
convinced
du coup
that
plusieurs challenges,
physiotherapy is
dernier challenge
absolutely essential
dont Alain parle
for patients' care.
sur la fidélisation du parcours, sur le
And
suivi des
finally,
patients,
you,
socio-émotionnel,
Guyguy, you
les
just
pertes de vie
mentioned
follow-up. C'est dommage
the problem of
mettre en
loss
place
to
une
follow-ups.
rééducation et que derrière tout ce qui a été gagné
It's really
va
a
potentiellement
pity that
être
people
perdu, en tout cas
who
va décroître.
benefited from
Et du coup, ça
rehab
m'amène à poser
are then
cette
lost to
deuxième
follow-up.
question.
So this
Maintenant
is a
que
cue to my second question to
on a compris à
you.
travers les expériences
On the face of the experiences and various projects that MSF and the MSF Foundation has led, we've come to understand that physiotherapy is important for patients' well-being as a whole. However, what are the questions we could or should ask ourselves whenever we start a new project in the field to make sure that the offer of rehab is more general? What would be the key success factors if we want to offer more rehab possibilities, opportunities? Should it go through general physiotherapy or a more dedicated form of physiotherapy, depending on the field? So what would be your must-have in order to have routine physiotherapy available across our projects?
Ce matin, il faut s'inscrire dans l'environnement local du projet.
I said this morning, I think we need to make sure the project fits in the local context, being in the Middle East or in Western Africa is something very different. Competing priorities have to be borne in mind as well. However, when it comes to physiotherapy, it should be really part and parcel of what's of our reflection around patients' care. Orthopedics, trauma surgery. Whenever we open a new surgery project, we know that also orthopedics and trauma surgery is going to be part of it. Likewise for burn patients or women's health. And also PEDS, we've got a lot of PEDS activities in our portfolio. So this side of the environment is important. Likewise, HR, whether these people are trained or not. And even if people are properly trained, well, these therapists may not have been exposed to pediatric physiotherapy, for instance. They may not know exactly how to deal with it. And so we have to wonder about the care package we can offer. I think we need simplified models. I said so several times, but I think it is important so that the teams can take ownership of the package as quickly as possible. Though, of course, we don't want to have the same package everywhere. We need to be able to fine-tune it, tweak it a little bit in order to adapt it to the field's needs. For instance, in Haiti, we know that follow-up is difficult. There is a lot of insecurity. Marc referred to decentralization and tele-rehab could offer a solution or even if you consider the situation in Syria during the COVID pandemic, we learned a lot of things. We provided them with packages so that they could have to come back only every month or every 2 months. So it's something that can feed in our thinking about adapted or appropriate care models, depending on or adapted to the environment we are in. And also HR is an issue that's got to be taken into account. And also we have to know that there are going to be more and more emergencies because of the armed conflicts. And what we could offer in Ukraine is down to the job of physiotherapists in Amman. Some people were and these people are very important. We don't have so many physiotherapists, so we need to have a system to decentralize our staff.
Juste, je pense aussi, il faut sur le plan médical, qu'on parte avec des objectifs qui sont réalistes. Et je pense, Alain disait tout à l'heure, on a des perdus de vue.
Okay, but I think we should also be realistic. There are lots to follow up, it's true, but there are also lots of criteria we do impose on ourselves. And maybe some of these patients left the cohorts because maybe, well, they thought it was good enough for them, or they had other problems to face, like in Gaza last year, I'm sorry. MSF people found it a bit difficult to just accept that we couldn't go much further than functionality, restoring functional limbs for the patients. And I think we should focus on what is functional for the patients. If maybe you could have done better, maybe the patient is never going to be able to run, but maybe for the patient, is it good enough for him or her to be able to walk? So maybe sometimes we do generate frustrations because the initial objectives are too ambitious and would require a review, because we are all faced with ever-changing situations. So you can't really say, well, this should be the care package with this and that objective, because this is not how it works. And in some cases, maybe we can have higher hopes and do better, but I think we should focus on the medical objectives and the care objectives for the patients and their families. Now, beyond the pure logistics and equipment issues that have to be taken into account, granted, we referred this morning to task shifting and task sharing. And as you were saying, objectives are very different, and the type of physiotherapy offered for in pediatrics or orthopedic projects and so on and so forth may be very different. And it's true, patients' expectations may not be as high as ours. And so we need to listen to the patients. We need to understand the patient's expectations. However, I'm just wondering whether there's some sort of minimum requirement for physiotherapy that could make a difference wherever resources are limited and where you would have to resort to task sharing and task shifting, because you see these physiotherapy, therapeutical exercise or management is quite demanding and requires expertise. So do you think you, as physiotherapists, that there are basic things, like basics, like stimulating the patient in the bed, that could help to reduce some of the risks and some of the complications? We mentioned caregivers this morning, mothers or brothers, sisters. A lot of our patients are supported by their families. So maybe this is something we don't rely sufficiently on. We should call upon families more often, and we could use them, or they could help us to ensure continuity of care. And also networking, as like the physio network, I think it is important. Maybe we can't and should not do everything. In a number of countries, there are partner organizations with which we can work. And we try to do so in some countries, not always successfully. However, I think it is worthwhile exploring these opportunities without, of course, any compromise on quality. But I think that maybe we could hand over some of what we do and refer patients to maintain continuity of care.
Moi, je veux juste peut-être ajouter sur... moi, je pense qu'on a monté ces expertises qui a pris un certain temps et on est assez
It took us some time to build up our expertise,
le niveau, la
and
possibilité de faire
I
et de
think
rapidité
that
de déploiement
we
de physio dans les contextes
know
chirurgicaux, brûlés, etc.
pretty well what is required from physiotherapy in emergency context. I think the work is still to be done for other specialties. And today, it is difficult to imagine a surgical project, even in an emergency situation, without physiotherapy. We wouldn't dream of going or opening a surgical project without physiotherapy. I think we still have this learning curve to go through to define what would be the package that could be rolled out depending on the context for women's health and pediatrics. Saying, well, in this sort of settings, this is what we should do for women's health or for children. And I think we're not there yet because we still need to gather some experiences to be able to fine-tune our packages depending on the settings. Interestingly, in Barmian, we managed to set up something that works without having a physiotherapist on site. Well, maybe it's going to be impossible to replicate Barmian elsewhere or on different grounds.
Alain, est-ce que tu veux rajouter quelque chose?
Alain?
Je pense que la grande partie est ressortie dans la salle et juste insister sur le fait
I agree with what you said. I just want to stress the following point. Everything should be adapted to your field, to the settings
Dans mon
you
expérience,
are
surtout les
in.
challenges sur les ressources humaines, effectivement, ça diffère déjà d'un pays à un autre, même si on a des difficultés
HR
sur
challenges
projet, pour avoir des
are
ressources
different from
qualifiées, pour
one
avoir
country
même
to the
des
next.
staff expérimentés à détacher. On a eu cette belle expérience avec, en Ukraine avec les amis qui venaient de Amman, qui faisaient un sacré
We
boulot.
had this
Et
very
on a eu
nice
cela lorsqu'ils étaient en
example
Indonésie, qui
of
venaient de Gaza,
detaching
qui avaient déjà
people
aussi
from
un niveau d'expérience.
seconding people from
Sur
Amman
des
to
activités
Ukraine,
spécifiques sur lesquelles
and
on a
it worked
déployé
well.
un certain nombre de compétences. Alors que peut-être ça
Likewise
ne
for
sera
some
pas
activities
adaptable sur
where we could deploy some physiotherapy skills,
c'est quoi les
but
compétences qu'on a
it may not be
jusqu'où on peut aller. Donc, du coup, ça revient encore
replicable everywhere.
des objectifs déjà médicaux, jusqu'où on veut aller, quelles sont les ressources
So we
disponibles,
need
et
to
qu'est-ce qu'on peut
define our
déployer dans
medical
ressources.
objectives, what
C'est
are
dans
the
ce sens-là où
resources that are
on
available.
arrivera
And I think this
les
is how
challenges et
we
les
can
défis qui
try
nous
and
attendent
anticipate the
par rapport à cette
challenges
pandémie et lorsque ces activités sont déployées.
and obstacles we may encounter.
J'aimerais rajouter quelque chose. Pour moi, il y a, bon, on a parlé du terrain, de différentes contraintes
Now
au
we
niveau
mentioned
purement terrain,
the
mais il y a quelque
field-related
chose à rajouter au niveau HQ ici aussi, parce
requirements.
qu'on sait que non, il y a la
However,
fondation qui supporte sur pas mal d'interventions
there's
sur le terrain.
also
Après, je me dis, quelle est
the
notre capacité
foundation
d'absorber ça
support
sans la fondation
in the
par exemple au niveau
field.
OP département médical.
But
Donc c'est, je pense
what
que
would be
c'est une
possible
réflexion
without the
à avoir. Ça,
foundation
c'est une
support?
réflexion structurelle. C'est une réflexion
Just
structurelle à
coming
avoir.
from the
Et
operations. So it's more of
après, je dirais que ben non,
a
je pense
review
que
of our
je dirais pas
structural
qu'il faut rajouter les
capacity.
RH, mais je pense qu'il faut réfléchir différemment en termes de comment est-ce qu'on peut travailler de manière transversale avec d'autres disciplines. On a vu par exemple Evgenia parler
Evgenia
on a
was
vu la présentation
referring
de Bamian ce
to
matin avec les
Bamian,
sages-femmes, il y a la partie
you know,
média
working
avec
with
santé mentale,
midwives
il y a
there
comment est-ce qu'on arrive
or
à
with
travailler même
mental
aussi
health
au niveau
experts.
HQ,
So
comment est-ce
what
qu'on
can
arrive à
we
travailler
do even at
déjà en transversal
HQ
avec d'autres
level?
disciplines
How
pour
can
qu'on
we
puisse,
work with
parce que si
other
on réfléchit de
disciplines
manière en silo, en vertical, il
in
faut qu'on
order
monte en
to
capacité en
make
physio,
the
ça veut dire que
most
non,
of
il
our
faut multiplier
HR?
par 3 le nombre de référents,
Otherwise, we would have
si
to
je dis on réfléchit sans,
multiply by 3 the
sans la
number of
fondation,
reference
c'est pas ça, tu vois, on n'est pas arrivé
or
à
the
ça.
number of
Donc pour moi, la première question à se
physiotherapists.
poser, c'est comment est-ce qu'on déjà on
So the
arrive
first
à
question to me
travailler
is to
ensemble de
know
manière
how we can
transversale avec
work
toutes les
better
disciplines qui
together
intéressent la physio.
across the
Et
board,
puis après, la
involving
question
all
de
the
comment
disciplines that may
monter en capacité
interact with physiotherapy, and how can we ramp up this
Juste un petit mot, je pense que c'est quand même risqué de faire
cooperation?
l'économie des ressources parce que
Well, I think it's a bit of a risk, you see,
rajouter des RH, mais
to
bon, la
avoid
fondation,
having
si elle est pas
more
dans les OP, ça
human
reste des
resources.
ressources
And
qui
you're
sont
right to say,
attribuées,
of
enfin,
course, the
qu'on met à
foundation
disposition
is
de la
not
physio. Donc c'est quand
part
même
of
des
the
ressources existantes qu'il faut compter.
operations
nécessaire.
and operational physiotherapy, but it's part of the resources on which we can rely.
Intéressant, mais ça reste quand même un pari risqué de monter une opération que sur des détachements.
I think it's a bit of a risk to rely only on seconding
On a eu quand même de la chance d'avoir des
Amman physiotherapists to Ukraine, for instance. We
gagné
were
d'avance
lucky to
et
have
ça
people
demandait quand
who
même
were
une
willing
sacrée
to
adaptation à
volunteer.
Amman de voir des physios tourner en permanence vers
And it was
l'Ukraine.
not
Il y a
easy
quand
for
même eu des ressources
Amman
maquillées.
to see the
Et c'est
physiotherapists
pas simplement les gens
coming
d'Amman
and
qui ont été
going
faire la physio en Ukraine,
constantly.
c'est aussi ils ont été remplacés à Amman.
And
Donc finalement, on n'a pas tellement économisé de ressources, on a juste
and
travaillé
these
sur
people who
l'échange de
left for
compétences
Ukraine had
et
to be replaced in Amman.
d'expériences. Et
So
ça, je pense, ça a été un véritable succès.
it was a success
Mais
because
ça nous a
it
pas
meant
permis
exchanging experiences
d'économiser des
between
ressources
Amman and Ukraine, but we didn't save anything in terms of HR.
Par rapport à cela. Non, je suis tout à fait d'accord, 100%
No,
d'accord avec toi.
I fully
Juste
agree
par
with
rapport à ça,
Marc.
on sait qu'avec les RH, je vois pas les ressources humaines ici, je sais pas
Where
si sur la
are
table.
the HR
Mais
today in
pour
this
tes
room? I don't know.
sur
However,
les ressources médicales,
whenever
RH,
we
c'est
have a
parmi les disciplines
meeting
en souffrance. C'est
with
une
HR,
spécialité très en
we
souffrance
know that
en interne, en termes
physiotherapists
de
are
nombre des physios. Et au moment où toutes les activités sont en train de
really
monter,
very
les besoins
scarce
sont en train de monter. C'est
in our
pareil aussi pour
pools.
la santé mentale et psy. On
Likewise
oublie
for
que
mental health.
ça fait partie
These are among the disciplines where we don't have enough people. And I do agree with you. We can't just rely on detachment or seconding people. Now, the objective in Amman is to be a center for excellence. So the thing with Amman is to make sure that OCP makes the most of Amman.
Et après, je pense que ça répond à une partie de ta question, mais je pense que la pluralité de la kiné rend les contours beaucoup plus difficiles parce que par exemple,
physiotherapy is something which is associated with a lot of diversity.
Mais effectivement, pour sortir un malade du lit, ça ne nécessite pas un kiné. Si un kiné, ça aide au moins.
Like we know, for instance, that mobilizing patients after surgery as early as possible is something which is going to reduce mortality. But you don't need a physiotherapist to do that. And this is why I was mentioning a whale, because there are different types of patients there. Mothers, babies, burn patients. So I think becoming too specialized, too much of an expert, may be a problem. So maybe we need to stick to things that can be easy to implement. It's true when you're surgery. I mean, whereas physiotherapy may be either very complicated or something. Let's say that the scope of physiotherapy is much more difficult to identify. Whereas it's not the case for nurses or doctors or surgeons. Physiotherapy is at the crossroads of so many disciplines, and I think it's part of what makes the discussion and reflection difficult.
Expérimentation, elles vont pas être simples parce que j'ai l'impression elles peuvent pas être générales. De ce que vous dites, du coup, elles vont vraiment dépendre du type de mission.
On the basis of what you just said, everything depends on your mission, your setting, the requests. Is it more of a post-acute care or highly specialized care that is needed? However, I think you really highlighted the resources on which we can rely, people who are trained or even specialized in some disciplines, and that could be seconded to the projects. Also, people available on site and who could be trained to supplement the teams. Now, this multidisciplinarity with task shifting and task sharing in some situations seem to be quite difficult to achieve. In some cases, we need to share our skills to guarantee the quality of care. Now, all these points are very interesting. And as Evgenia was saying, I think it's important to realize that maybe in some cases or in some missions, you may not need physiotherapy. Doesn't mean you're not going to do rehab. However, we may realize that on the basis of our resources and the emergency, it may not be the top priority. And as you were saying, Guyguy, it's because you have all these competing priorities in missions. So thank you very much, because all of you, each one of you is shedding some light on what we heard so far. And in line with these questions, I'd like to ask you, how can we make all this become sustainable? You mentioned what the foundation does and how it is included in MSF, but what can we do within MSF to better organize the the rehab offering. And to answer this question, I'd like to ask one of our colleagues to introduce the foundation model and the thing they set up with this pool of physiotherapists. And maybe you can tell us what sort of interactions there can be. Thank you, Matthieu.
Décrire un petit peu ce qu'on a essayé de monter à la fondation. Il y a des choses qui sont pas tout à fait nouvelles, mais ça va permettre de voir un peu, sans répondre à des questions, ça va faire des liens avec ce qui a été dit.
No, I think I'm not going to answer any questions, but I think it's going to be in link with what we've heard so far. So, to summarize how we proceeded, we had a first survey in the field within MSF France, and we got 50% of return, and we said, okay, pediatrics, women's health, burn patients seem to be important. So we decided to have people who are experts in these various areas, and we recruited a team. People, Elizabeth, Lucie, they are sort of in between MIO and referent. They spend half of their time in the field and half of their time at HQ to try and solve situations, identify missions where physio rehab may be needed. So this is what we implemented. And it's also a way to tackle the problem we had with the international pool. There's been a fall in the number of physiotherapists in the international pool. Firstly, because there are fewer projects with surgery, and traditionally physiotherapists were involved through surgery. Secondly, in our missions that are long-standing missions where we have rehab, rehab is now something that is covered by locally hired staff, and therefore the size of the international pool of physiotherapists has decreased. However, as you could see, IMS, the expats are still important because we have an offering that is more differentiated and more specialized, and this is the model we try to set up and nothing new here, but we try to promote the HR level locally to provide clinical capacity building so that these people are adapted to what they see in the field, and also to support them to become leaders one day, so that they can become they can be empowered to and they can participate in the international pool one day as well.
Ça, c'est vraiment sur le côté RH. Après,
that's for the HR function. We've also tried to be as realistic as possible. What is true for one setting is not true for another. That was the case for pediatrics, as shown between the two projects in Katsina and Kano. Had we kept the same criteria in Katsina, we would have needed an army of 20 physiotherapists. So we needed to adjust the criteria and the patient management. And it also means that we need to specialize and define what will be the scope of physiotherapy And what are we going to actually manage, or what is it that we're going to manage differently? No, for the future, as far as the foundation is concerned, the project is slightly involved in operations, but not forever, because our funding will stop at one end, at one point. So we will have to find a way to make a decision between the head office, the section, and intersection. So either reinforcing capacity in the field so as to have a staff that is in a position to respond to these needs, and then see what we can do with outside partners, which could be Handicap International or others. There is the International Organization of Physiotherapy, World Physio, which does promote networking in the various countries and training in various countries. And these are possible avenues we can use to train as a function of the contexts where we are present. And lastly, in terms of research, it's not about the how efficient our activities are, but Marion said it earlier. What type of models can we have, and what are the rehab models that we can have as a function of the context? I'm sorry, it was a bit long. I've tried to summarize what we've discussed and what we are trying to implement on the side of the foundation. Thank you, Pierre. No, I'm turning back to the panelists. What is your view on this? What's your take on this, on the integration of rehab, based on what you know, what you're familiar with, and your ideal integration of rehab in the care package? Thank you, Pierre. I think that is a question that we'll have in the back of our mind.
Une des parties qui ont profite de fondation, c'est vraiment cette partie de
the benefit of the work of the foundation is that it is experimenting models and putting new ideas on the agenda. I did appreciate what the rep from Kano said about research and what you have said regarding the description of models, which may be taken up again in the future by MSF or maybe by others. This is something that may accelerate the process we are familiar with, so that we can help further with our experts.
Je sais pas à quel point, dans quel terrain on peut profiter.
I don't know to which extent we can benefit from the sharing of experience
niveau spécialité comme pédiatrie et santé des femmes.
With the highly specialized programs such as pediatrics and women's health. You've mentioned the challenges you've had in Nigeria, that is that you couldn't find specialists. But maybe we need to search more, or maybe try and work with existing institutions which will be a source of expertise and which can keep on developing their activities independently from MSF. That's what we've tried to do in Iraq. We start to transfer our expertise with MOH in Iraq. It was not really a success, I must say, because in those countries where we operate, physiotherapy is far from being a priority. But maybe we didn't allow for enough time to look into that further with the local authority. So maybe the operations with the help of foundations could carry on with this work and trying to see demonstrate the added value of this expertise.
Je vais compléter par rapport à ce qu'Evgenia a dit, je suis tout à fait d'accord.
I'd like to add and say that I agree with all this. I'll give you a practical example. This morning, we'll talk about Katsina and a huge volume, and Raphael, the medical coordinator, has put in the balance the quality of care and big cohorts of patients. Now, the foundation has worked on the pediatric rehab. That's very good, but when we talk about HR, let's go back to what Pierre has said. At the end of this project of the foundation, how is it that the medical department and the ops department are going to take in all these aspects? We'll have to anticipate when there are specific projects where well-defined resources, earmarked budgets. We need to get prepared for the next phase, for the next steps, because if we wake up a bit too late, it won't help for the continuity of the physio projects. So we need to anticipate for the future. We have seen that for pediatrics, we have to put on the table physiotherapy, mental health. We need to work with the team of the foundation so as to anticipate and try and see what could be developed during the peak period and off-peak period, and also work with the medical coordinators. I'm thinking about nutrition reference, pediatrics reference. What is it that we can do for the cases of retraction, of edema? Do we have 800, 900 beds? Or shall we focus only on retractions? And what about the neurodevelopment of the child? Do we include it or not? So what do we do as a function of the environment where we are present? Because you can go from 800 down to 100 bed. You know, you have huge ups and downs, and it does have an impact on the quality of patient management and quality of care. So I think that we need to think about these models, which will not be copied and pasted for all projects and all missions, but, you know, have something, you know, a template, a model, which can be used by the teams to adapt to their local realities. Pierre also said something about it. I remember working physiotherapists who were former Handicap International workers. So they were asking, you know, and we were asking, do you have equipment or do you have devices? So we're out of the usual MSF silos. So it's important when you work locally to identify the local players and work as a network with those who are doing the same thing as us. And for training, I didn't have the time to ask the question about Jahoun. They said that there was some training in Jahoun with a training center. Those who came for training were MSF OGBA people, but nobody from the MOH staff. Or maybe there were some, but I couldn't see whether it was actually done or not. Now, if we can do that in a given area, how is it where we can produce knowledge locally? That would be helpful.
Alain, on peut peut-être te laisser un peu la parole aussi.
Alain, you have the floor.
Oui, merci. Je pense
Thank
que,
you.
après avoir suivi
I
Pierre,
have
effectivement, tu as bien décrit
listened
les
to
plans
Pierre. I think
qui
you
ont déjà
did well.
place et aussi ces
You described
stratégies
pretty
d'avoir
well the plan of the
des sortes de
foundation and
référents
the
autour de la
strategy
fondation qui
to
sont
have
présents sur
referent
différents terrains
people
et
from various fields
que je vois qui est en train
working within the
de se
foundation.
déployer surtout avec tout ce qu'on a rajouté côté women health.
And I see also what was added in terms of mental health and pediatrics. But now we need to have a broader plan.
Ces personnes, quand on le déploie, oui, effectivement, le nombre de physios sur le terrain, c'est différent.
When you see the number of physiotherapists to be deployed in the field, and as we've said, we have to assess the existing resources in the field, and we have to have a strategy to share this experience and knowledge so that the teams of the foundation are not overwhelmed. I think that every time we ask ourselves questions, we've had local visits made by representatives. It takes some time, and they're very busy with all that. So, as you've said, it's important to cooperate with other partners. But what type of partnership, what type of collaboration, with whom? And how can we integrate those in our operational strategy? And how can we adapt it to each and every project? Maybe when introducing this type of reflection in our projects, it will help to make our approaches more sustainable. That's all I wanted to add. Thank you.
Alors, je pense que la fondation fait un peu pour moi en tout cas, le proof of concept.
To me, the foundation is providing the proof of concept, how feasible, and then we have to see how at MSF we can make it a standard tools and, you know, so that people know better about what we do, how we have find the resource people. Once these expertise is in the field, we are all potentially faced with a difficult situation. So we have to have these contact point or resource people. And once again, talking about physiotherapy and cross-cutting issues, we have peer counselors, you know, mothers telling other mothers what is to be done. We shouldn't depend too much on in Haiti. We've had great difficulties because there was a high turnover in our teams, supervision, surgical, medical teams. So you need to have a bit of physiotherapy, mental health, a bit of clinical teams, you know, physicians, nurses, surgeons who also contribute so that it works. Otherwise, we will be too much dependent on one team in settings that are fragile. And now to compare it with other topics, moving away from medical topics, sometimes we stepped back. I'm thinking about POCUS and Minilab. It's true that on paper it makes a difference for the patient, but when you look back in history, you realize that we didn't have the foundations to add the Minilab, the ultrasound, etc. So maybe this is what you would need to define. You know, the level 1 of physiotherapy should be, I don't know, physiotherapists in the country. If you don't have any physiotherapists in the country, then you have an answer to your first question, and then move on. What are the needs requirements for pediatrics, for obstetrics, and say, well, for this particular field, it would be nice, but we're not ready. This particular mission has made more progress. And, you know, you kind of have some standards. It will be on a case-by-case basis for sure. And this will probably help us take in this physiotherapy thing so that it's not a flop, so that it's not a failure. I have no problem with quality going up and down as a function of time. When you have bronchiolitis everywhere in the French hospitals, you do not provide the same type of care as in April or in the summer. So let's face it, I don't think it's a problem per se. You have to adjust to the ups and downs of the activity volume. I think you've said it all, more or less. It's difficult to talk about this. You know, sustainability is a difficult question because physiotherapy has a short history at MSF. We said the first physiotherapist was in 2005, 2006. So it has taken up over the last 10 years since the foundation has taken up the topic and capitalizing on knowledge. Well, the way I see it needs more work because the models will be very different from one country to the next, and it's very difficult to reproduce a model. So when we talk about research, I think it's important to review the models, to study them and try and see what can be done to simplify them so that they can be reused, at least partly, in some missions. It's not research to convince ourselves that what we're doing is the right thing, but really research aimed at seeing whether this activity can be made operational and be reproduced. And as far as I'm concerned, as you've said, we've tried with MOH, but we didn't push further for it. We were having the patients were seen in IPD, then they were discharged. We were seeing them in OPD several weeks after, so there was a huge gap. It took us months for surgeons to provide a physiotherapy prescription, a single prescription. So it's been very difficult. We didn't have all the means and resources, but it was worth thinking it. So the physio model, pre-op, post-op treatment, being close to the patient, that's very specific to amond, but what are the lessons that can be drawn for other fields? We've heard this morning that there were some difficulties in terms of equipment. It's true that mothers do not always have a phone. It's not always possible everywhere. And as you've said, if we don't have the basics, then it doesn't work. And we've worked on advanced post in case of earthquake in Atme. It was after the earthquake in Atme for earthquake victims and severely burned patients. But trying to reach out patient is also one thing to be done when the patients cannot move around. These are some of the models we're trying to work on. But it's difficult. Very briefly, I'd like to add the following. We're not mainly familiar with the hospital and not community-based management. I think that many of our hospitals are not open to the families. I spent 50% of my time in ICU. Now, though, we are still with models that are the ones of the government models, you know, 1 hour visit in the morning, 1 hour in the afternoon. We have small structures. It's difficult to meet with the families and difficult to engage them in a care journey or pathway, except for mothers and children. But in a standard hospital, we have little access to the families that can act as a relay so that the treatment will be shorter, so that the patient will perform his exercise after discharge and will alleviate the post-op follow-up. So beyond physiotherapy, there are other things to be considered and not only purely physiotherapy. It adds an additional brick to the implementation of physiotherapy, and it shows how the patient can be managed in a holistic fashion, considering the local environment, local communities and families. No, it's in line with the 2030 WHO plan, One Health the International Federation of Physiotherapy, World Physio, is promoting the presence of physiotherapists worldwide with development programs, initial training in those countries where such training does not exist, so as to have this awareness-raising effort for all, because physio is not systematically considered in a conventional care setting. I think that MSF has taken the right, avenue for physiotherapy. That's very good. It's an excellent initiative. No, through your project and your respective experience, there are some answers to some of the problems that do exist at the international level. And each time, based on what we've heard this morning and what I hear from you, I hear you say, well, we have problems, but we find alternative solutions. We rely on external solutions, external partners. We make sure that we assess the needs properly. We try to anticipate as much as we can. And this anticipation problem, it seems that there is a battery problem with the microphone. Ah, no, here we go. Anticipating will be the spearhead of the forthcoming projects. The foundation has shown through its projects that it was feasible in various locations on various topics which were not initially considered, like pediatrics and women's health. And now, make this feasibility something sustainable and concrete, while taking into account all the cultural, financial context aspects and HR, which will always be at the very center of the debates. Now, if you agree, we will have a discussion with the floor. We have roughly half an hour, is that right? Okay, 40 minutes. We may discuss if you have questions. You in Paris on the various topics, if you want to, comment or I'll be moving around with the microphone. There are a few questions online. Two comments and people reporting their experience, and two questions. Colleagues from Bangui who wanted to talk about their experience with the patient charter. I will try and give them a microphone. And we also have Aman. They would like to report about their experience regarding the network physio. We will first give the floor to Bangui.
Bonjour à tous.
Good afternoon, everyone.
Donc, je pense que vous nous écoutez.
I hope you can hear us. Please introduce yourself and give us your comment.
Voilà, moi c'est Justin. Je suis responsable
I'm in charge
de la personne pour la mission en RCA.
Of the CAR program. We have a surgical program. And since 2024, we've started the deployment of the patient charter. And what I wanted to share with you is what this charter has meant in terms of physiotherapy. With the conventional medical model, we were focusing on you know, appointments with the patient, standard physiotherapy sessions without considering the specific needs of the patient. And when the patient charter was deployed, we have been able to model and improve the patient management. We've insisted on the quality of care, on information provided to the patient so that patient would understand the physiotherapy treatment, and we've also emphasized the need to see the patient as a partner and the fact that physiotherapy could also be performed at home. There is also the respect of the patient in the patient charter. Respect meant that the relation with the physiotherapist was improved. So that's all I wanted to say regarding the use of the charter. So it really helps for the patient-centered approach, generally speaking.
Merci. Merci.
Thank you. I don't know whether some people would like to respond to this. Thank you for this report. There was also Lina in Amman. I don't know whether she's still online with us. If not, I could also mention two questions in the chat. One from Nigeria, which talks about the setup differences and difficulties when you have MSF staff on the one hand and MOH staff on the other hand. Have you observed any difference, you panelists, when you have MOH staff with incentives or MSF staff as to the introduction of physiotherapy, the sustainability of this activity on site? Well, thank you for this question. I think that it depends pretty much on the project model. The physiotherapists are not separate or isolated actors in the project. I have no specific answer regarding the physio staff. But if the physio expertise does not exist in the hospitals, the MOH with whom we work, quite often these positions are added by MSF. So quite often these are MSF staff. Personally, I have no experience with the physio from MOH, except for the project Marc and I have mentioned when we provided some support to the MOH for the capacity building of their physiotherapy capacities. But it has revealed some difficulties. It was quite successful with the physiotherapists who've expressed a great interest to, you know, freshen up their knowledge, to implement the practice. But really what mattered was the, and what was missing, the model of care from hospitals during the patient hospital stay. And when the patient had to go from IPD to OPD, how to ensure continuity of care and also compliance and interest by other healthcare professionals on physiotherapy management. I'm not sure I've actually answered your question, but this is what I can say about it.
No, no. Non, non, je pense que tu as répondu à la question. Non, non, c'est juste que je suis.
Yeah, it does answer my
j'étais en train de
question. Thank
réfléchir
you.
par rapport à,
I was just thinking aloud
l'intervention de Justin
and
tout à l'heure. Je me disais non, ça
about
ne pouvait pas
just
passer
what
inaperçu, d'autant plus que ça
Justin
fait
said
partie de nos
earlier.
priorités
I think it's really a
institutionnelles,
part of our
la charte
institutional
du paiement et la charte du
priorities
patient. Et
and
surtout
the
la question
patient's
de faire
charter
du patient,
and the fact that
on
we
parle des
want
soins sans pression du
to
patient, maintenant on
have
parle de
a patient-centered
patient
approach
partenaire. Donc ça,
and
il est tout à
patient
fait en
as
jour par
partners.
rapport à nos priorités
So it's
institutionnelles.
really in
Et
line with
tout
our
à l'heure, on parlait de la
institutional priorities.
pérennisation. Et je pense que non, passer par cela, ça doit faire partie des bases
And
sur
we
lesquelles on
want
doit
this
s'appuyer,
to become
travailler avec le
sustainable.
patient,
So we
travailler comme
really need
partenaire,
to
pas centré
have
sur le
this
patient,
in
mais
our
le patient, il est
basics. We
partenaire
really need to
de la prise en
consider
charge.
that
Je pense que non,
patients are
physio fait
partners
partie
in
des
the
disciplines où,
management of care.
Evgenia l'a bien mentionné
And
au début,
Evgenia said
que
so.
ce sont même les physios qui nous ont alertés
And I
par
think
rapport
really we have to be
à tout
grateful
ce qu'on
to
doit développer sur
physiotherapists
sur la
because
santé
they
mentale,
really
sur
highlighted
communication avec le patient. Ils passent
everything we
beaucoup de
have
temps
to
avec le
do
patient. Donc
to
je pense que non,
communicate
sur
better
l'exemple
with our
de
patients.
Justin,
And so
passer
if
là, je
I
pense que non,
go back
normalement,
to
c'est quelque chose qui doit
Justin's
être
example,
généralisé
I think it's it's something that
dans
should
tous nos
be
projets. Donc merci Justin pour
extended
ton
to
intervention.
all our projects. So thank you very much, Justin, for what you just said.
Si je peux rajouter juste quelque chose à ça, ça me fait penser à quelque chose. Ça nous fait aussi le lien avec une des difficultés qu'on avait, qui était la représentation.
Well, this is very much in link with
handicap, mais aussi autour des patients
how
et aussi
we
de leur
understand
entourage.
rehab
Quels outils on peut mettre en place. Donc là,
and how patients and their relatives understand rehab.
extrêmement intéressant. Mais
And it's true that the patient's charter is important, but we have to provide patients with tools that can help them to better understand what we do for them and appropriate take ownership of what is done for them. Now, I still remember the experience in Douya back in 2007. These were burn patients. And these patients had gone through the whole pathway and they were back to explain to other patients what a skin graft is, what sort of scars it leaves. And this greatly helped patients to make a decision about having a grafting procedure or not, or coming back for rehab. So it's not easy to do things like that, but it's quite effective if you want to improve communications with patients.
Ça montre, ça me fait penser à ce matin en santé de la femme où vous parliez des femmes qui vont après témoigner dans
Well, it's a bit like what you said this morning about women in women's health projects who went back in their villages, explain what they did, and it's true that we can have patients as experts, and this is something which is recommended by the public health authorities, the HAS in France, because the patients themselves have some knowledge about how to live with a disease or with a condition, or how to behave through a given type of care. And it's something which is very useful for MSF settings where the cultural aspects are very significant, are very important as well.
Mathieu, juste pour que tu saches, on a...
C'est juste pour, non, juste pour ajouter sur ce point précis.
Now, on this particular point, now patients as experts, patients as educators, as trainers, is something which is really a part of what we want to do for a patient-centered approach and therapeutic education and patients as partners. This is really a part of our reflection on this.
On a, je sais que Lina qui est à Amman
Now, Lina in Amman would like to
sur lequel elle travaille.
share with us about the project she is involved with on the physio network and what patients do once they are back at home.
Thank you, Pierre, for giving me the chance to speak. I want to thank you all for inviting us to participate in this Rehabilitation Day. I want to thank Marc for highlighting the role of Network Physio in Amman project and the tele-rehabilitation and the continuity of care for the patient with no access to health and care in home countries. This is Lina, the Network Physio Supervisor from Amman Project RSP. During today's discussion, we will rightly acknowledge the valuable contribution of the physiotherapy, occupational therapy, and other rehabilitation team. However, I noticed that the continuity of care after this face-to-face rehabilitation ends, particularly through tele-rehabilitation, was not addressed. Although we need to continue physio after discharge was mentioned as a challenge and a need in almost all presentation. This is critical gap. Once patients are discharged and returned to home, they still require ongoing support to ensure they achieve the maximum benefit from their rehabilitation goal and gain the functionality that help them functioning well in their lives. So the Network Physio Rehabilitation Initiative in RSP, we continue providing physiotherapy remotely and face-to-face by referral to facilities and NGOs in home country, and even hands-on session by the Network Physio themselves in home country, helping patients progress in their recovery journey at home, in school, and within their community. Our Amman Tele-Rehab project is the first of its kind across all MSF missions and OCPs, and it has demonstrated significant impact. This model not only enhances patient outcome, but also improves hospital capacity by enabling faster discharge and higher patient turnover. Tele-rehabilitation is not just a technical solution. It is a strategic approach to ensuring continuity, accessibility, and the quality of care for all patients, wherever they are. It is extension of care that bridge the geographical, logistical gap and ensuring that no patient is left behind. To be honest, if I'm going to talk about the network physio, it will take too much time, but I will go to brief exactly the impact of network physio on the project. It was very critical in reducing, for example, the length of stay in the hospital before and after surgery. I will give one example. For the pre-TT surgeries, we reduced the number from 36 days to 23 days, and post-tendon transfer from 92 days to 64 days. Same for other like THR and 3D TFO patients, which means early discharge from the hospital, trusting that the network physio will follow the patient in their home country. And we gained this trust because the surgeon team started to have the brave to send the patient back to continue their follow-up in home country. The most important thing and impact that we just do some analysis for the data, and we discovered that 76% of postponed surgical patients on physiotherapy improved enough to avoid surgery and coming to Amman for surgery just by the network physio intervention in home country. As a conclusion, to advocate for and invest in the tele-rehabilitation as a cornerstone of sustainable patient-centered care, I'm fully ready to share this successful experience and support any mission interested in implementing our tele-rehabilitation successful experience. And thank you very much.
Well, thank you very much for your brief presentation. Indeed, tele-rehab could really help to develop in some countries where the geographical area is an issue. So thank you very much.
There's a question in the audience. I do have a question and a comment. A question to the foundation and the operations. Now, physiotherapy is something which covers a very wide ground. And very rightly, you decided to focus on highly specialized areas of physiotherapy. And so, following our discussions today, one would be tempted to hope for physiotherapists that would be as multitask or as versatile as possible. But do you think it's possible? Do you think it would be possible to make things more compatible with the operations? It would be great to have people who are highly specialized everywhere, but it's not feasible. So what can we do instead? And secondly,
mais je pense que c'est important d'insister dessus.
rehab.
La rééducation, la rehab, évidemment, la place de la physio, elle est prépondérante dans cette approche-là, mais c'est
means much more than just physiotherapy, and we all know that physiotherapists insist on mental health, health promotion, involvement, engagement with caregivers. So this is this continuum that seems to be quite important, as several people have said during the day. And I think it should be included in our future development at MSF. How can we make sure that things become more sustainable and our patients become more independent and empowered?
Alors, on va peut-être prendre d'abord une réponse de la Fondation, puis après du panel.
Pierre ou Julie?
Julie, est-ce que tu veux...
Ouais, je peux commencer à répondre, mais enfin, Julie, si tu veux compléter, ou même les filles, parce que
No, thank you for this question. I don't know whether that I have an answer to it.
Mais je pense qu'on a décidé aussi d'être dans
But you see, we decided to go for a highly specialized approach because we thought it was more appropriate because we're still learning. Up to now, we didn't have a lot of feedback on the management of patients who are malnourished with physiotherapy.
De facto, on a plutôt été orienté, on va dire ça comme ça, sur des secteurs spécifiques.
Likewise for women's health, with VVF, surgery, and breast cancer. So, and we're just about to touch upon the issues during the perinatal period. And we also know that we will have to do something for victims of sexual violence. And likewise for pediatrics, there are other populations of patients, such as patients with children with sequelae of meningitis or malaria. So I'm still not answering your question. However, I'm telling you all this because what I mean is that once we do have more knowledge and maybe we will have a possibility to set up models to take care of all these needs and maybe reinforce the link between what we do for mothers and what we do for children.
Merci pour la question, Julie.
Thank you, Julie.
Pour compléter ce qu'a dit Pierre, je pense que je voulais dire à
peu
près la même chose. Là, on est au commencement.
We're just on the start of our journey.
C'est intéressant d'avoir des profils très spécialisés parce que sinon, on ne sait pas évaluer un patient en malnutrition qui n'a jamais été évalué par aucun physio.
So this is why we wanted to have people who are specialized, for instance, in pediatrics, because we didn't know how to assess a child who's malnourished. But there are physiotherapists who can, for instance, in France, work with mothers and children. So maybe we'll be able to combine these profiles And there's a question on the hospital, about the hospital in Awale or in Aidan, and these physiotherapists retrained on other aspects of care.
Et peut-être qu'après, quand il n'y aura plus la fondation, on n'aura plus nos spécialistes qu'on a aujourd'hui. Mais par exemple, ce qui a été fait en Syrie, qu'on n'avait pas encore accès, c'est l'équipe de Gaza qui est spécialiste en
For instance, if you remember what we did in Syria, we sent the Gaza team to train people in Syria on the management of burn patients. So it may be something we can replicate elsewhere.
En fait, j'ai un retour de terrain parce que je travaillais pendant 9 mois en tant que
for 9 months
par exemple, si je donne l'exemple
in Aidan.
en fait, je suis
I
partie en tant que kiné
was
spécialisée en pédiatrie,
a
mais j'étais
physical
pour continuer
physiotherapist
l'implémentation de
specialized in
l'activité que Lucile a commencé.
burn patients.
Mais on
However,
recevait des
we
patients, on voyait des
also
patients
had to
post
deal with patients after
post-FIR, on voyait aussi des
surgery,
patients brûlures et j'étais
and
amenée
I had
aussi
to train
à
the
former
teams
les
and
équipes, les accompagner
support them
pour
to
fournir le meilleur
take care
soin
of our
possible
patients. So
pour nos
as a
patients. Du coup,
physio,
en tant que physio,
it
pour
is very
l'implémentation, je
important
pense que
to
c'était
have
très
this
important d'avoir ce
pediatric background
en pédiatrie parce que, comme elle a dit Lucile, par exemple,
for
avec les patients Kwashiorkor,
POSH
on sait pas en fait. Il n'y a pas d'intervention, il n'y a pas de
patients. So
protocole
there's
bien
no
défini. Et du coup, c'est très bien d'avoir
well-defined
ce
protocol.
background,
So it's good
plus
to have
d'expérience dans
a
un domaine
background
particulier,
that
mais
is
aussi j'étais amenée à former les équipes
appropriate.
parce que notre rôle, elle n'est pas limité à
And I
l'implémentation, mais
had to
aussi
train
on
the
a le devoir à
teams
fournir le meilleur soin
so that
possible
they
pour les
could
patients qu'on reçoit.
ramp up their
En pédiatrie, à Katsina,
skills.
on recevait des enfants
In
avec
Katsina, for instance,
brûlures.
there were children with burn.
Neuro aussi, on avait des profils assez variés. Du coup, je sais pas
So
si
I
c'est un retour
just
de
want to
terrain.
give you
Pour
my
moi, c'était très
feedback from the
utile d'avoir
field. I have to say that I
l'expérience en
was happy
pédiatrie,
to
mais
have a
aussi
background in
j'étais amenée
pediatrics,
à intervenir
but
dans
I had
d'autres
to work
domaines,
with patients
neuro-traumato-brûlures, pour fournir
after
la meilleure qualité.
surgery or
Je suis pas
in
spécialiste en
patients
brûlures, je suis
with
pas très
burns.
spécialiste dans d'autres
Now,
domaines, mais
I'm
j'ai la
not
capacité
specialized
à
in these
former pour fournir le
on these
minimum,
issues, but
la meilleure qualité.
I was able to train people to deliver the best possible care.
Une petite remarque rapide, c'est que je pense qu'effectivement, je voulais un peu dire la même chose.
Yes, when you start, you need people who are specialized, but you don't want to end up with so many silos. So it's a good thing that we can train physios to do different things than the ones they are used to. We launched pain management programs with a nurse who is specialized on pain management. However, pain management is something that we should all be able to take care of.
Non, je pense qu'on est tous d'accord par rapport à ça. Moi, je pense que non.
Yes, the first implementation should rely on experts. However, then there should be a transition phase to become more
Après, sur le portfolio de manière
open.
globale, au niveau opérationnel, moi, je dirais que à un certain moment, ça serait bien de faire une balance entre l'aspect des centres
It would be great if we could have a sort of balance between reference or excellence centers and the other centers, because we can't just have or replicate a man everywhere.
C'est pas les mêmes moyens, c'est en termes d'expertise, il faudrait qu'on sache où mettre en place.
So we need to identify where we should build up our knowledge and how to extend this to other
J'en
settings.
reviens à mon package de soins, mais c'est vrai que si on a un kiné 5 étoiles mais que l'infirmière, elle sait pas faire un
Now,
produit en croix pour donner les
we
médicaments, ça fait pas trop de
also
sens. Donc
need
effectivement, je pense que
to
ça sera toujours
pay
la même histoire, c'est
attention
que
to the
chaque terrain
setting
sera un peu différent.
specificities,
Mais
but
l'idée, c'est d'avoir sur
when
les endroits où on a plusieurs
this
populations
is
de
a
patients, qu'il y ait
project
des
with
gens
several
capables de faire
populations of
au moins
patients,
la
well,
base
we
pour
should make
plein
sure
d'autres
that
choses, et après d'avoir des
we
personnes
have a
d'accord,
basic team able
Pierre, Julie, pour
to
l'état actuel des choses, et peut-être d'autres, mais
deal with
pour
these
justement les fois
patients
où ça dépassera leur
with some
connaissance,
experts
compétences, où
on
ils auront
whom
besoin
they
d'être
can rely
guidés, confortés dans
to
ce qu'ils
get
font.
some
Mais
guidance. I think
je
it
pense
is
le
the
modèle
most
le
type,
plus pérenne.
or let's say the most sustainable model we can implement.
Est-ce qu'il y a d'autres
Further
réactions,
questions or comments?
Moi, je voulais juste revenir sur quand on parlait de
Now,
pérennisation
making
et
things
notamment, par exemple, transfert
sustainable
de
and
compétences au
transferring
MOH.
handing over to
Et je voulais
the
préciser par rapport au
MOH.
cas du Nigeria qui a été envoyé ce matin pour la
Now,
pédiatrie, pour leur
in
faire, j'insiste quand même,
Nigeria,
il y a une
we
information qui est mal
recruited
passée. On a
physios
recruté
who
des
were
kinés qui avaient une
experienced in
expérience en pédiatrie,
pediatrics,
mais qui n'avaient
but
pas
no
d'expérience
experience of
avec la malnutrition,
malnutrition
parce que
because
c'est
it's
pas
not
enseigné dans
something
les
they
écoles de
get
kinés
to
là-bas.
learn in their
Et je voulais donner l'exemple
at
dans
school.
pour
And
le transfert de
so
compétences
when
au
we
MOH,
had to hand
l'exemple de
over to
Waka
to the
à
MOH,
Kano,
um,
qui, je l'espère, ça va fonctionner, mais qui normalement
Waka
vient de
just
signer
signed
un MOU avec
an
le MOH
MOU
à
in
Kano,
Kano
et pour devenir
to
structure,
become
un peu comme
like
un
a
teaching
teaching
hospital,
hospital
structure
for
exemplaire
the
pour le
treatment
traitement de
of
la malnutrition,
malnutrition
parce
because
qu'au
there's
Nigeria, dans les
no
hôpitaux, il n'y a pas
unit
d'unité de
in
malnutrition.
Nigerian
Donc c'était,
hospitals
voilà, c'est un exemple
specialized in
qui va
malnutrition.
essayer d'être mis en place.
So
Et
in
donc,
our
dans notre unité de
nutrition
malnutrition à
unit in
Kano, on
Kano,
a maintenant des kinés qui vont
our
bientôt, l'année prochaine, avoir
physios
1 an d'expérience clinique et qui
next
seront
year
aussi à
will
même de
have
recevoir
1 year of
les kinés
experience,
du
so
MOH
they'll be
et de
able
leur
to
transmettre ce que je leur avais
transfer their
transmis lors
knowledge
de
to MOH
l'implémentation.
physios, as I did when we launched the project.
Merci.
No,
Donc,
thank you. We
les
can
défis
see that there are
sont
many
encore nombreux, mais
challenges
les expérimentations
with
sont
very
de
good
très bons exemples.
examples of.
On a encore le temps pour une question, puis après on va
Now we do have the
finaliser
time to take one
éventuellement
more
le
question.
panel.
Otherwise,
Non, bon, alors,
we're going
du coup, moi, j'ai
to
une dernière question à vous poser.
give
Plus une question là,
the
on va
panel
dire de
the
réactivité
floor
par
for
rapport à toute la
conclusions.
journée
However, before we do so,
qui s'est déroulée aux différentes
there's one
présentations que vous
question
avez
I'd
eues,
like to
au
ask.
débat que nous avons eu ce soir.
Should you
Si vous deviez retenir, je vais vous demander 2 mots.
keep just 2
2 mots
words
seulement
to
pour
characterize
caractériser
our
un petit
day,
peu la journée
our
à travers
meeting
voilà, les
today,
présentations, les témoignages,
listening
les
to
expériences.
the
Donc,
various
qu'est-ce que vous en avez pensé? Voilà, un mot
experiences and
sur ça.
talks.
Et le deuxième mot, ce
And
sera sur
secondly,
la suite, la projection.
what
Qu'est-ce
about
qui, selon
the
vous, va
prospects?
être important? Donc, je vous laisse quelques secondes même pour
And
aussi
of
faire
course, I'm
l'exercice et
turning
voir
to
si vous
the
trouvez un petit peu
audience.
les mêmes mots.
And just
Et
to
pour
give
laisser
the
au panel le
panel
temps de
some
réfléchir,
time,
Alain, je vais te
Alain,
désigner en tant que premier
you're going
répondant.
to be the first one to
Voilà. Parce
give
que là, du coup, à
us
distance, on ne peut pas laisser
the
beaucoup la
2
parole, donc je te
words
laisse l'honneur ou désolé si la tâche est un petit peu difficile. Mais
to
voilà, 2 mots
characterize
pour
this
caractériser un petit
meeting.
peu la journée et puis la suite par rapport à
And
la réhabilitation
what
au
about
sein
the
de MSF.
prospects?
Voilà, je te laisse la parole.
No, thank you very much.
Merci beaucoup. Oui, moi, c'est que
Oh, 2
si je dois
words,
résumer en 2 mots, même
not
si
easy.
c'est pas facile. Je pense que le plus important, c'est pour la réhab, c'est de voir comment
The most
opérationnaliser,
important thing for
adapter
rehab to
nos ambitions au
make
niveau
things operational
opérationnel
and adapt
et
it to our operations
à les adapter
and adapt it
au
to our
contexte dépendant, de
settings
sorte
so that each
que chaque
project
projet ait sa propre expérience adaptée au contexte, adaptée à sa population, à sa culture,
fine-tunes things so as to be
au
in
niveau
sync
du
with
pays
the
du projet.
settings and the
Donc,
population and the
je pense
culture.
que ça permettra, c'est qu'on anticipe les
And
difficultés qu'on va trouver, les challenges, et
I think
qu'on
it's
se rende
important to
compte si
anticipate
les
challenges
soins ou
and
les activités dont
obstacles
on veut déployer sont possibles à être faits
so as
sur
to
ce lieu et
avoid
ne pas se mettre en difficulté.
getting stuck.
La deuxième des choses,
And
c'est
secondly,
effectivement, cet aspect
lifelong training, I think, is important.
La stratégie
and
de la d'avoir cette équipe
the foundation with its team of specialists is right. However, we need clear strategy so that the experience, the teams, experience can be shared with others, and so that not everything is left stranded once the foundation stops supporting these activities. Now, these are the two things I'd like to keep in mind. Thank you very much, Alain.
Merci beaucoup, Alain. C'était un petit peu plus que 2 mots, mais bon, comme tu étais le
It
premier,
was a bit more than 2 words, but going first was difficult. So now I'm going to use 2 words only. Well, maybe a bit more. I'd say proximity with the patient, to the patient, being patient-centered, close to the patient. It's a bit like what you do as a physio. And secondly, also the thing is that we would like to be transversal, and also there's this notion of being across the board or cross-cutting. Well, apparently we're all in agreement.
Avec ça, donc c'est une journée riche. Moi, c'est que j'écris riche
So,
et la transversalité. Mais bon.
Cross-cutting, transversal.
Non, c'est pour moi le.
Are the 2 words that stand out.
La richesse
the wealth of experience also,
nouvelle chez MSF, mais
and how it has become increasingly important in our operations. So I enjoyed a very fruitful discussion today. And about the prospects, well, being able to work with others, with mental health experts, with health promotion, with so physiotherapy is not just for physios. We didn't cheat, believe me, but being transversal, well, it's because these medical issues are across the board, and also it's because it starts in the hospital, but it goes beyond the hospital, in families, among caregivers. Now, there's also this cross-cutting approach between the foundation and the operations, and we know that also had discussions with the Red Cross. So it's really something that stands out, and thank you very much for your contributions and what you do for the patients every day in the field. The care you provide, and also the high quality time you give them as well. So thank you.
Oui, moi, je pense que mes mots pour la journée étaient peut-être un peu plus proches de ce que Marc a dit. Ça
Yes, being really close to the patients and
des physios
between physiotherapists and patients, because physios have a role to act as their advocate and supporters, getting the patient's message across to the rest of the team. And as for the prospects, I think hope would be the word I'd select. I think we are improving. We still have
things to do,
on a vu
but
comment on a pu faire les
we
bails et je pense
have
qu'on
started,
peut continuer à le faire parce que c'est dans le physio ailleurs,
and it goes to show
ça montre
that
quand même
we do have the
voilà,
means
la
to
puissance
do
de
that.
ce qu'on peut faire si on y croit, quoi.
Well, thank you to
Bien,
all of
merci
you
beaucoup
for
pour
having
vos témoignages, pour votre participation
taken
à
part
cette
in
table
this
ronde. Evgenia, Aurélie,
panel
Guyguy,
discussion.
Matthieu et
Aurélie,
Alain,
Evgenia,
merci beaucoup
Guyguy, and
pour tous ces
Alain.
éléments
I hope
de
these
discussion qui, j'espère,
debates
ont
have
été riches et ont pu du coup faire mûrir en vous
helped
plein de nouvelles
emerge with new
idées, en tout
ideas
cas
for
pour
the
la pérennisation
sustainability of
tous
the
ces projets.
project. We
Je
can
voudrais qu'on les applaudisse
give
si
them
on
a
peut.
round
Ils
of
sont rendus
applause.
disponibles.
I'd like to thank them. I'd like to thank the
Merci pour eux,
foundation
merci aussi à
for
la
having
Fondation pour
organized
organiser
this very
cette belle
interesting
journée.
day.
Puis du coup,
And I'll leave
je
it
vais
up
vous
to
laisser le mot de la fin
the
pour
foundation
clôturer cette
representative for
journée
the
ensemble.
closing remarks.
Je vais commencer pour le mot de la fin. Je commence après Claire.
Claire will come with the final words, concluding words. Thank you to all of you.
Non, merci à tous. Et non, nous avons commencé par ça, mais je ne terminerai
I'd like to
sans
pay
rendre hommage
tribute
à nos
to our
4
4
collègues de
colleagues in
physio qui ont
Gaza who were
été tués
killed
par
by
l'armée
the
israélienne.
IDF.
Je pense que dans une pensée
So I wanted to
pour eux,
mention it.
je
We
voulais le
said it
mentionner.
in the beginning, but I
On
wanted
l'a mentionné au
also to
début et à la fin, je vais
mention
dire
that we think
on
of
pense à
them,
eux. Donc,
Ahmad, Omar,
Ahmad, Omar,
Fadi,
Fadi
Berin.
et Rim.
And also,
Et après, deuxièmement, je
I'd like to thank you
merci
all the
à tous
speakers,
d'être là, à tous les intervenants
MSF speakers, and
externes,
those who came from
internes
outside, and those who were online in the
qui ont pu
field and
contribuer
who've
également à ces
also taken
échanges.
part in our
Merci à vous. Les
debates,
discussions étaient
which
très
were
riches,
very interesting, as you've heard.
comme on a tous dit à la fin.
We've
Et à la
all
partie,
observed
donc nous avons
that
tous vu
physiotherapy
l'évolution
has
de la
changed
physio chez
at
MSF
MSF
depuis
since the
les années 2000
beginning of the
jusqu'à aujourd'hui,
year 2000 with the
avec l'alerte des
surgeons
chirurgiens
who've said that we have
très
to be as
très
close as
comme
possible
d'habitude,
to the patient.
blessure.
And with
Et
the
avec
orthopedic
l'évolution
and
plus
severely burnt patient
avec des champs de
and
plus en plus
broadening
élargis
the
sur la santé
scope,
de la femme.
including
Et aujourd'hui,
women's health
développons la
and
partie
pediatrics.
pédiatrique.
It's very
Ça,
good.
c'est
And
très bien.
there is
Et donc, il y a toute la question qui
and maybe the
elles verront un jour
NCDs
sur les NCD.
may be included in the future. We don't know. This is to be explored.
À être explorées plus tard.
We haven't
la question de violence qu'on n'a pas
looked into the question of violence
mentionné.
enough,
Et
probably,
au
but
niveau
for operations, it's also part of our priorities. That is a proper patient management for the victims of violence. These will be avenues for the future. As to what does already exist, there is the recognition of disabilities, the recognition for the need of physiotherapy, for the fact that physiotherapist is truly a job, a profession, task sharing versus task shifting. How can we develop a local network and develop local partnerships? There is also the follow-up care, which could be a problem in our settings with sometimes limited resources. So we have to be very creative when it comes to our models of care. So resources, budget, what are the priorities? So thank you to all of you. Now, as to what the foundation has done so far, congratulations on the organization of today's meeting. Congratulations on the work and the support provided to the teams. So it's really at the forefront of everything. Now, in the future, we will have to see how operations can take physiotherapy on board and have models that can be adjusted to our models, which can be made sustainable. And then there are certainly avenues for operational research. We will have to consider research not for the purpose of demonstration, but have different models and proof of concepts. It is something we'll have to look into. And thank you to the teams in Jahoun, in Banyan, the teams from Kano, and for having reported your so rich experience. Now, finally, I'd like to talk about access and 3D and prosthesis. It was very interesting to listen to this discussion this afternoon and the availability of such devices in the field. This should also be part of the future topics. What else do I have to add now, says Claire? I'll talk about the patient's charter. Well, it was a very interesting day. This morning's presentation, and I wrote, well, I should say it in my conclusion, but you've said it all. So very little to add. 2 to 3 things, maybe. First and foremost, MSF has moved from life-saving to quality of life care as far as we can, developing these quality of life aspects that are very important. And, you know, cancer treatment is also a way to promote the quality of life of our patients, even though we're not sure we can cure all the patients. It's an example that needs to be mentioned. And physiotherapy, from surgery to physiotherapy, but we're also working on NCDs. Maybe in the future we will deal with heart infarction, cardiopathy, cardiovascular diseases, so we can imagine what may happen. And this helps to link up with rehab in a more general term, the rehabilitation medicine, which is multi and interdisciplinary. It's very important. It's not an additional layer. It's also about linking up these approaches, the patient-centered, mental health related aspect, all the aspects of physiotherapy within rehab. But you have also all the types of prosthesis you can think of, and all the people who are involved in the management of disability. We are fortunate that Julie Pacro, for several months, is going to work on how we can integrate rehabilitation medicine. What is it that we can do at MSF? So we'll have the opportunity to work on these famous cross-cutting or transversal aspects you've all mentioned in your conclusion. And since I'm the director, I will be repeating myself and say, well, we have to set priorities. Once again, we want to go for physiotherapy for all the patients who need it, but it's not possible. You know, setting priorities, it's part of our job at MSF. Everywhere in all projects we work in countries where there are huge needs, and we may go for this rather than that. We have to be ambitious, but we shouldn't be too ambitious and be creating non-feasible expectations. Pediatrics and women's health are 2 key aspects we can further work on, but it has to be done on a step-by-step basis, and this is to be kept in mind, so as not to create too high expectations, as I've said. Once again, it's incredible what we do at MSF. We have people are very high, good profile, dedicated to their patients in the field, here in the head office. So thank you to all of you, and thank you to the foundation, because without this project, we wouldn't be here today. Even though we do have the intention and the skills, there was no such momentum. And the way you've worked on a project basis did help to launch something at MSF and to work differently. It's a very interesting model of work. Thank you, Julie and Julie. Thank you to all the people who were involved. And I'll stop here. My 2 key words are thank you and see you soon. Thank you. I'd like to take this opportunity to thank the people in the field who were online, Nigeria, Yemen, Jordan, Chad, Palestine, Central African Republic, and Malawi. We were very happy to have you with us online. Thank you to the various panelists, speakers who've taken the necessary time to take part in this meeting in spite of your busy agenda. Thank you to our partners and the staff who worked on that, Abder for Handicap International and Matthieu for the French Society of Physiotherapy. We're very pleased to have you with us today. And finally, I've written evolution and involvement, engagement. Evolution, we've seen that MSF has evolved in its patient approach. There is still some evolution to be expected, and then adapting to the reality and how we can adjust to the reality in spite of the limitations and engagement or involvement in the field and at the head office. This is something that we've seen at the scale of physiotherapy, how people are helping patients relentlessly. Thank you, Claire, for these very kind concluding words. Thank you and see you soon.